ব্যাগে দেখতে পাচ্ছি কোথায়
Good evening, everyone. We welcome you to OrthoTV online. This is a special webinar on pain procedures of the spine and has been brought to you by the Spine Society of West Bengal. To hand over, to proceed, to go with the proceedings, I hand over to Dr. Amit Jain to introduce the speakers and today's topic.
So, very good evening, all the faculty members as well as the delegates. I would like to introduce the term biological plasticity, which means the ability by which we can adapt ourselves to the changes which are happening in the environment. We know because of basically this property or this plasticity, we have been able to evolve so much, and we have been able to keep the other races or all the other beings like animals far, far behind as compared to ourselves, that is humans. But of course, this evolution, why it has happened, all of us are aware that it has happened because of increasing brain size over the time. Initially, it was somewhere around 300 cc, 500 cc, and now we have almost reached to 1350 cc, which is Homo sapiens brain size, which has helped us to really evolve and to adopt with the changes which have happened. Now, with this evolution, there are many changes, I would say, streams in which we have progressed, including the health stream. In life sciences and healthcare as well, we can say things are changing at a very drastic rate. Like previously, when we used to manage any patient, it was not we, I would say our forefathers, it was trial and error method. And then we went to how to manage on the basis of some of the data which is available. Ultimately, it became an evidence-based healthcare, then precision-based healthcare. Then finally, now we are into translational medicine. And now we are going towards personalized healthcare depending upon what that particular patient really needs. There is a paradigm shift in healthcare. Now it is not one size fits all. Now it is basically personalized medicine for everybody, for every person specifically. Now it is not provider centric, not based on what the doctor likes. It is based on patient centric, what that particular patient needs. We are moving from invasive to less invasive methods of managing the patients. And ultimately, rather than treating the sickness, we are moving towards preventing the sicknesses or moving towards the wellness. But yes, even today, with this growth, when we treat so many patients, it is clinically proven that there are almost 3 to 5 clinical questions per day which remain unanswered in a physician's mind when he's practicing. So where to find the answer to these questions? Obviously, it should be from the research which is happening. But the time taken from a research publication to the time it comes into real practice, that duration is so long, you would not believe it is almost 17 years is the time in which the research, in first time when the research is published and by the time it comes in real practice. So how to shorten this time? To shorten this time, we need something which is called as CME, that is continuing medical education, so that the people who are doing research or the people who are more learned, they can share this with their fellow colleagues, and ultimately all of us can evolve, and all of us can practice the same thing as fast as possible. Obviously, for this interaction, with the help of this interaction, we will be able to improve our clinical performance that ultimately will influence the quality of healthcare outcome. That definitely needs physical meetings like conferences, which we used to do just a few months back. But now, because of the COVID times, we'll not be able to continue with the physical meetings. So here the digital platforms are helping us with this help of these webinars. So with this background, I, Dr. Amit Jain from Medical Affairs Department, Intas Pharmaceuticals, on behalf of Inara division, which is specifically dedicated to the management of osteoporosis, invite all of you to this live exclusive webinar, which is on pain procedures related to spine. Today, this is basically being held under the Spine Association of West Bengal. And to go ahead, we have a wonderful panel today. And our chairpersons today, we have Dr. Indrajit Ray, and it will be moderated by Dr. Kunal Sen Gupta, sir. Doctor, it is my, I would say, fortune that I am just introducing, sir. Dr. Kunal Sen Gupta is a very senior consultant spine surgeon from Kolkata. And he has quite a good number of publications in his hand and has also a wonderful, I would say, clinical, I would say, clinical things which he means clinical practice is wonderful. And sir is well known not only in West Bengal but across India for his clinical things. So I would not take too much of time. I would just like to hand over the session to Dr. Sen Gupta, sir. Over to you, sir. You need to unmute your mic, sir.
Dr. Sen Gupta, you need to unmute yourself. Yeah, now
Now?
Yes.
Yes. Hello?
Yes, we can hear you. Go ahead. Muted again. You are muted again. Please unmute. Yes, we can hear you now. Please
Right?
go ahead. Please go ahead. Please go ahead. We can hear you now. Please go ahead. Dr. Sen Gupta, we can hear you.
Are we audible to you, Dr. Sen Gupta, sir?
Hello?
Yeah, we
Yes,
can
sir,
hear
you can
Yeah.
please proceed, sir.
Can
Yes, sir,
you
please
listen
proceed,
to me?
Yes.
Yes,
we
yes.
can hear you.
Right?
Yes. Dr. Sen Gupta, we can hear you very clearly. Why don't you remove your headphone? It will be better. Dr. Abrar Ahmad or Dr. Basu, can you take over?
Okay. I think Dr. Sen Gupta is having some problem. So I will like to invite our first speaker. First speaker is Dr. Chinmay Nath. Chinmay, you start your presentation.
Yeah, thank you. Good evening, ladies and gentlemen. Today, in this webinar of SSWB on pain procedure related to spine, I will speak on pathophysiology and chemical mediators of spine. Though it is an uncharted water for an orthopedic surgeon, I will try to cover the topic on several subheadings like introduction and definition of pain, description and classification, pain receptors, pain pathways and relevant neuroanatomy, physiology of pain transmission, chemical mediators, and some clinical situation which is relevant. So pain is an elaborate interaction between sensory, behavioral, and emotional aspects. And a unique thing is past experience of pain can dictate an individual's future response regarding pain. That is very important. The word pain came from the Latin word poena, which means it's a penalty or punishment. In the Middle Ages, it is called penalty. The International Association of Study of Pain, IASP, defines pain in 1996 as a unpleasant sensory and emotional experience associated with actual or potential tissue damage described in terms of such damage. IASP purposefully avoids the tying pain to the stimulus. So there may not be any stimulus in the pain. Pain is a subjective experience which cannot be easily measured. It requires consciousness. Describing pain as an experience separates pain from nociception, which while nociception is an objective phenomenon, it's a neural process involving the transduction and transmission of the noxious stimulus to the brain via a pain pathway. So pain is result of complex interplay between signaling system, modulation from the higher centers, as well as unique perception of that individual. So same pain can be different for the different individuals. So what is the difference between nociception and pain? Nociception is a neural encoding of impending or actual tissue damage. That means noxious stimulation. Pain refers to a subjective experience of actual or impending harm to the individual. Although nociceptive stimulation usually leads to pain, pharmacological and brain lesion research shows that one can exist without the other. There are different types of pain. Most commonly is a nociceptive pain, which may be superficial or deep, and it can be divided into two types: somatic pain and visceral pain. There are other types like neuropathic pain, referred pain, thalamic pain, psychosomatic pain, as well as the phantom limb pain. First is acute or nociceptive pain. Nociceptive pain refers to the pain that is associated with the actual or threatened tissue damage and involves the activation of the peripheral nociceptors. It is caused by injury, disease process, abnormal function of muscle, or viscera. It may be of two types, somatic or visceral. Now, coming to the somatic pain. Somatic nociceptive pain may be sharp or dull aching in nature. It is well localized and consistent with the underlying lesion. The examples are metastatic bone pain, fracture pain, dental pain, post-surgical pain, and arthritic pain, etc. Now, coming to the chronic pain, the pain that extends beyond 3 to 6 months or beyond the expected period of healing of the lesion. It may be nociceptive, it may be inflammatory, neuropathic, or functional in origin. The psychological mechanism or environmental factors are present in case of chronic pain that is not present in case of acute pain. Now, acute versus chronic pain. Acute pain is sudden and it is of short duration, while chronic pain is insidious and it may persist after the healing of that lesion. There is warning signal or warning sign of actual or potential tissue damage in case of acute pain, and it may not be present in case of chronic pain. The acute pain severity correlates with the amount of tissue damage. In case of chronic pain, severity may not be related with the tissue damage, and there may be psychological aspect in the chronic pains. CNS involvement also present in the chronic pain. Now, visceral pain, that is a unique scenario. Visceral pain, the organs or nociceptions, they respond to the mechanical stimulation such as pressure, tissue damage, and chemical stimulation. These are the viscera, the stomach and intestine, and it is the bladder. And from there, the afferent neurons, they are going through the autonomous nerves into their ganglion, and from their ganglion to the dorsal root, maybe autonomic ganglia, to the sympathetic ganglion, to the dorsal root ganglion, and where there is interaction between the somatic neuron, the red colored dotted line is the somatic neuron afferent, and there is interneuronal connection between the autonomous and somatic neurons, and then the proximal nerves go to the dorsal horn of the spinal cord, and there is interneuron, there is synapse, and there is the second order neuron started from there, and which goes to the thalamus and through the brain. I'm coming to the interaction. Hello. Now, visceral pain pathway, it may goes to the somatic nerve as well as the autonomic nerve, just like sympathetic or parasympathetic, to the spinal cord, and from there to the hypothalamus and brain. Now, difference between somatic and visceral pain. Somatic pain is well localized, while visceral pain is poorly localized. Somatic pain, the density of the receptor is very high in somatic pain situation, but on viscera, the density of the nociceptor is very low. So affected afferent fibers are well represented in cortical mapping. In case of somatic pain, in visceral pain, it is poorly represented in cortical mapping. That is why it is visceral pain is poorly localized. Delta and C fibers of the sensory fibers travel from the somatic, in case of somatic pain, to the somatic afferent, while delta and C fibers of the visceral pain travel through the autonomic afferent. Autonomic pain may be colic in nature and is accompanied by autonomic disturbance, which is not present in somatic pain, and response to pinch, prick, cutting, crushing, etc. in case of somatic pain, while the visceral pain is the response to distension, inflammation, and ischemia. There are another type of pain called neuropathic pain, which may be peripheral, which may be central. Then neuropathic pain is accompanied with some upward sensations like burning, paresthetic. It may be lancinating pain, it may be electric light shooting, etc. It may be paroxysmal, it may be continuous. There are certain other features of neuropathic pain like allodynia, where the painful response to the normally innocuous stimulus. So abnormal hyperalgesia, the pain in abnormal severity following the noxious stimulus, and hyperpathia, hyperesthesia, dysesthesia, etc. There are common causes of neuropathic pain like disease process like infection, inflammation, neurotoxicity, tumor infiltration, metabolic abnormality, therapeutic intervention like surgery, like chemotherapy, radiation, etc. Trauma like external injury, nerve compression, inflammation, etc. There are certain common situations of neuropathic pain like post-herpetic neuralgia, painful diabetic neuropathy, low back pain, radiculopathy, neck pain with radiculopathy, spinal cord injury, and stroke. The nociceptic pain differs from the neuropathic pain.
Hello.
And I describe it. Nociceptic pain is well localized, while neuropathic pain is not well localized. Nociceptic pain is sharp and works with movement. Neuropathic pain is burning, shooting, numbness, pins and needle sensation is present. In nociceptive pain, obvious tissue injury or illness is present always. In neuropathic pain, tissue injury may not be present. In nociceptive pain, injury, inflammation and tissue damage causes the nociceptic pain, while the nerve injury, abnormal firing or abnormal stimulation, loss of modulation may cause the neuropathic pain. Now, there is a certain another pain, called type of pain called referred pain. That is the convergence between somatic pain and visceral pain. The visceral afferent fibers from the viscera goes through the sympathetic ganglion, and it meets with the somatic afferent fibers from the skin, and it passes through the dorsal root ganglion into the dorsal horn, and there is interneuronal connection. So the brain does incorrect perception and falsely refers to the somatic source, even though the stimulation came from the visceral source. So the gallbladder pain may be represented to the shoulder. The pain from the myocardial infarction may be represented to the scapular pain or arm pain. Now, thalamic pain, it is also another subset of pain. It is called Desirine-Rossi syndrome. It is caused by stroke or occlusion of the thalamo-geniculate artery. It is centralized and neuropathic type. Now, psychosomatic pain. Psychosomatic pain is a psychic reaction to pain, includes the all well-known responses to pain such as anguish, anxiety, crying, depression, nausea, and excessive muscular excitability. It may be associated with post-traumatic stress disorder, fibromyalgia, somatization, depression, etc. This is a unique representation of the psychic pain. See, there is no injury at the receptor level in the skin, and the afferent fibers, somatic afferent fibers, maybe a delta or C, they are intact, and up to the dorsal root ganglion also intact, and there is also dorsal horn, and it goes to the dorsal horn and goes crosses the spinal level and goes to the thalamus and to the brain. But problem is in the descending pathway. The descending pathway is not working, and it is not inhibiting the ascending pathway. That is why ascending pathway, the normal stimulation it goes to the brain as a excitatory stimulation, and it is represented as painful stimulus. Now, phantom limb pain. Phantom limb pain is being the pain perceived by the region of the body which is no longer present. It is the experience of the pain without any signal from the nociceptor. It is experienced by the amputees. There is certain situation in which the neuropathic pain and the nociceptive pain overlaps. It is called mixed pain syndrome, which has neuropathic characteristic as well as nociceptive characteristics. Examples are low back pain with radiculopathy, cervical radiculopathy, cancer pain, carpal tunnel syndrome, etc. Non-nociceptive pain is often dependent upon the central sensitization induced by the prior or ongoing nociception. Therapeutic methods which minimize the nociceptive afferent activity is important in prevention or elimination of this type of pain. Now, coming to the receptors. First is I will discuss the nociceptors. Nociceptors are the free nerve endings of the nerve fibers. It is widely distributed in skin, dental pulp, periosteum, and meninges. There are two main afferent fibers generated from the nociceptor. They are A delta and C fibers. There are three types of nociceptors: highly threshold mechanoceptors like HTM receptor, polymodal nociceptors, PMN receptors, or silent nociceptors which respond to the stimulation. They are activated specifically with painful stimuli, heat, mechanical or chemical tissue damage. Now, this is the pathway of pain pathway, where the transduction, and there are four important steps like transduction, which happens in the transduction which happens in the tissue injury level at the free nerve ending nociceptor, and transmission which goes through the first order neuron or afferent neuron through the dorsal root ganglion into the dorsal horn, and at the dorsal horn there is a synapse, and where pain modulation happens, and from the synapse second order neuron starts, it decussates the spinal level at the and to the opposite side it goes up, so as a spinothalamic pathway into the reticular activation system, then to the thalamus. From thalamus third order neuron there is another synapse, and from thalamus a third order neuron starts which goes to the cortex, and at cortex the brain perceives. This is perception, and according to that perception brain interprets or behavioral changes happen. These are the 4 important steps of pain. The neurons are known to the primary component of the neural system. It connects, receives and processes all the nociceptive information. There are 3 types of neurons: sensory neuron, interneuron and motor neuron. It consists of a body called soma, action, either myelinated or non-myelinated. This is the action, this is the body, this is the action, and they are dendrites. All neurons are electrically excitable. Now synapse is very important thing, and I compare it with a river. There is the proximal bank of the river, the end of the first proximal neuron, and where there are synaptic vesicles containing the neurotransmitters, and with the action potential, these neurotransmitter containing vesicles attach with the cell membrane, and by exocytosis the chemicals go into the synaptic cleft as a chemical mediator of pain or chemical transmitter, and these neurotransmitter binds with the crosses this river and binds with the opposite bank receptors are the opposite bank, and it the chemical phenomenon transmitted into the electrical phenomenon. So electrical phenomenon, then chemical phenomenon at the synapse, then electrical phenomenon. Then synaptic transmission begins with the arrival of the action potential at the presynaptic action, which I have already told. An action potential at the presynaptic terminal creates membrane depolarization, which opens the sodium channels at the terminal. This is the action potential. It may be resting potential or threshold potential. The action potential are more there. How action potential is generated? There is more sodium accumulated outside the cell than the potassium inside the cell. So there is negative charge inside the cell, which drives the action potential to be generated. There are in the synaptic transmission, there is one stimulated by 2 types of potentials are generated. 2 types of potentials are inhibitory postsynaptic potential and excitatory postsynaptic potential. Once the triggering threshold is reached, the action potential propagated through the action, and when action potential travels to the calcium ion enters into the presynaptic terminal through the voltage gated calcium channel, and hence causing the synaptic transmission. Now this is a step-by-step representation: entry of the sodium ion, then further activation of the VOCC, then calcium enters into the action terminal, then fusion of the synaptic vesicles to the presynaptic action terminal membrane to the neurons, and release of neurotransmitter to the cancer into the synaptic cleft, which I've already told. Then free neurotransmitter diffuse across the synaptic cleft, binds to the
conclude now.
get neurons, and there is termination. Now very important is how the neurotransmitter is transmitted. If it is not terminated, then second action potential will not be generated. So there are 4 possible ways: drift of the neurotransmitter away from the synaptic cleft, removal of the neurotransmitter by the glial cells, enzymatic degradation, reuptake. Then transduction of the neurotransmitter happens at the synapse. The stimulus event is converted to the mechanical event by the receptor, then it transfers to the neurons, and then at synapse it is again converted into the chemical receptor. Then pain pathways. Are the primary afferents. There may be high threshold mechanoreceptors or polymodal receptors, and go to the spinal cord and where the gate control happens, and through the spinal cord, spinothalamic tract and spinoreticulating tract goes to the brain, and from brain a reverse direction, downwards descending tract, which controls the pain mechanism. This is the upward pathway from receptors. These the dorsal root, from the dorsal root ganglion, these 2 fibers go to the dorsal horn and then crosses and then goes up to the brain. Now coming to the chemical mediators, there are certain chemical mediators, maybe inflammatory mediators, and some are non-inflammatory mediators, which mediates the pain. Inflammatory mediators are hydrogen ion, 5-HT, cytokines, prostaglandin, bradykinin, histamine, serotonin, etc. Non-inflammatory mediators are GABA, opioids, glycine, cannabinoids, etc. Now, neurotransmitter may be pain initiators. These are glutamate, substance P, bradykinin, prostaglandin, and pain inhibitors, which inhibits the pain. That is serotonin, enkephalins, endorphin, GABA, etc. There are certain groups of the neurochemical mediators, amine groups, noradrenaline and 5-HT. They causes increase in pain. Endogenous opioids like enkephalin, endorphin, they reduces the pain. Non-opioid peptides, a substance P that associated with inflammation, galanin, etc. Excitatory amino acids like glutamate, they act on NMDA receptors and they act on as pain memory. And inhibitory amino acids like GABA and glycine, the GABAergic drugs act in this area. They regulate the behavioral changes. Others are cannabinoid receptors. These inhibits the pain.
And you have exceeded your time. Try to conclude quickly.
Well, yes, just 2 minutes. Here the paracetamol works. Then pain mediators may be prostaglandin, bradykinin. These are the prostaglandin pathway. Then pain mediators may be hydrogen ion, 5-HT and other mediators. Now coming to the receptors. Receptors may be two types: encapsulated nerve ending like this and free nerve ending. Encapsulated nerve ending may be mechanoreceptors, chemoreceptors, or thermoreceptors, and free nerve ending are the nociceptors. There may be specialized nerve ending in the central nervous system. Now first order, there are 3 order neuron: first order, second order, third order. First order neuron traverses from dorsal horn to spinal cord, and its cell body is in the dorsal root ganglion. I'm rushing through my slides. The sensory nerve fibers are 4 types. One, A alpha, A beta, A delta, and C. A alpha is thickly myelinated and fastest, and C is the thinly myelinated, non-myelinated, and slowest. Now, the nociception is associated with A delta and C. A delta is myelinated, C is non-myelinated, A delta is faster, C is slower. So this picture is very easy to understand. The stimulation at the periphery, then it goes to the first order neuron into the synaptic cleft, the interneurons, and then second order neuron from synaptic cleft at the dorsal horn to the brain. This is the cross section of the spinal cord. Dorsal horn of the spinal cord is divided into 10 lamina. Among the 6 lamina makes the dorsal horn, and it receives all afferent neural activity. And these are the 6 lamina: 1, 2, 3, 4, 5, 6. The A delta fiber attached at 1 and 5, and C fiber. And this is the synaptic cleft. And the structure of the dorsal horn may be divided into lamina, which I have already told. The lamina 2 is caused substantia gelatinosa, and A beta fibers acts also over there to modulate. There are second order neurons which may be nociceptic specific, wide dynamic range, and low threshold. There are 3 types of dorsal second order neuron. It goes from the dorsal horn to the thalamus. And there are gate control theory, which is caused by inhibitory control by higher centers, activity of A beta fibers, and segmental modulation by certain chemicals like endogenous opioids, cannabinoid system, and inhibitory amino acids. These are the gate control mechanism: C fiber, A delta fiber, and A beta fiber, which cause gateway mechanism. And here there is a modulation. There are certain neural stimulations, such as chemical stimulation like GABA, 5-HT, etc. Enkephalin, they acts on this side. There are now the spinal tract. There are 2 types of spinal tract, like spinothalamic tract and spinal reticular tract. Spinal thalamic tract may be at lateral and medial. Lateral tract goes to the ventral posterior lamina, lateral nucleus of the thalamus, and go to the brain. It controls the sensory discrimination of pain. Medial tract causes autonomic pain, and spinal-reticular tract, which controls the diffuse, emotionally disturbing pain. It goes to the thalamus or hypothalamus to the brain. Then third order neuron, which runs from thalamus to the cortex. Then brain perceives the pain in the cortex insula, anterior cingulate cortex, and prefrontal cortex. This is the pictorial representation of the pain perception.
Can you conclude now? Now you're exceeded 20 minutes now.
Now, sorry. This is the peripheral and central sensitization. Now, factor separating post-surgery pains are different: nerve injury, tissue injury, tissue ischemia, inflammation, and there is prolonged post-operative pain, which inhibited by anesthesia, pain medication, psychological support, and pain information. And there is nerve root injury. Nerve root injury may be avulsion, stretch, and rupture, and it may be preganglionic or postganglionic. This is the cascade of nerve root injury, and there are peripheral sequelae. And there are altered distribution, altered expression, and altered gateway property of sodium channels in case of nerve injury. Then there is another phenomenon called neuroplasticity happens after nerve injury, which causes the neuropathic pain. Then nerve root compression, mechanical or chemical, and this is a mechanical effect. This is the chemical effect. It induces the intraneural edema and reduces the intraneural blood flow, histological changes in the nerve root. Now, this is a biochemical effect. Now, finally, the local anesthetic, how local anesthetic acts. It acts by blocking the voltage gated sodium channel, which I have already told. There are three parts of any local anesthetic: lipophilic part, hydrophilic part, and intermediate chain. And it blocks the sodium channel and drives away the calcium ions, and blocks the development and propagation action potential. There are two types of local anesthetic, like esters and amides. Amides are long-acting, like bupivacaine and ropivacaine, and medium-acting actions are lidocaine. And this is how local anesthetic acts. It's in the periphery, in the peripheral nerve, in the nerve root, and in the brain. There's a factor affecting. There are certain factors affecting local anesthetic action: epidural fat, the vasoconstriction, local inflammation, etc. Thank you very much.
Okay, thank you, gentlemen. I don't think we have time for question answer. I will request Dr. Anindo to present his presentation. He's going to present orthoscopic anatomy of the sacroiliac joints, neural phenomena.
Am I audible, sir?
Yes.
Can I request all speakers to please stick to the time?
Yeah.
Right.
Ananda.
Yeah, 1 second, sir. Trying to share the screen.
Go to share screen.
Yeah, but I can't find my screen.
And then on the first window on the left, you click and then click on share again.
While Anindo is getting ready for his talk, this is Dilip Sengupta, and I'm very excited and listening to this talk. I have got to break away for my surgery starting now. This is morning time, but all the best to you guys. Thank you.
Thank you, sir, for joining.
Sure.
Right. I would like to start today thanking the seniors for giving me this topic and for organizing this seminar, because I hope to learn a lot from this. It's something which we practice pretty regularly, all lumbar injections and spinal injections. So my topic today is fluoroscopic anatomy of neural foraminae, lumbar facets, sacroiliac joints, and sacrococcygeal joints. I'm Anindo Baswe, working Institute of Neurosciences, Kolkata. And right, so neural foramina, the anatomy of neural foramina. It is very. I'm not going into anatomical details. What I would like to emphasize in my talk today is a few radiological concepts which I find very useful during my clinical practice. So let us first start with this, the Scotty dog view. This is basically an oblique view of the lumbar spine, which we all use for our injections. So let's see what are the different parts of the body of the Scotty dog are. So this you can see, this is a very good radiological Scotty dog view that you've got on the right side. The Scotty dog has been marked out. The eye of the Scotty dog is basically the pedicle. The nose of the Scotty dog is basically the transverse process. The ear of the Scotty dog is a superior articular process. The foreleg of the Scotty dog is the inferior articular process. And then the hind leg and the tail forms the hind leg is the inferior articular process of the opposite side, and the tail is the superior articular process of the opposite side. And you've got the spinous process somewhere in between the body, as well as the lamina here. The pars is the neck. So this is what we want to see when we do nerve injections. Most of us, although some people use the AP view for doing their nerve root blocks and for transforaminal injections, as well as vertebroplasty, but I like to use this Scotty dog view a lot. So let us see how this is helpful. So this is another slide where right L5S1 foraminal axis has been described. The C-arm angle, as you can see, the idea is to make the end plates parallel, to see the Scotty dog view, to see the eye of the Scotty dog, and the needle can be placed accordingly in the 6 o'clock position if you are aiming for the subpedicular approach. And again, in the lateral view, where you have to make the end plates very parallel to each other, so that you've got a proper lateral view to work with. And these are the CT corroborations of the same. So this is what you're aiming at, most of us, when we are doing our transforaminal injections. So First, we have to obtain a level-specific AP view. Then we have to oblique the C-arm towards the desired axis size and until the superior articular process. The ear of the endoscopy is approximately 2 feet of the length of the disc and plate, lines posterior to the anterolateral vertebral body margin. So this is kind of an ideal angulation of the C-arm to provide produce a like a classical Scotty dog. So the classic fluoroscopic target, the subpedicular target, is about at the 6 o'clock position of the pedicle, which is the eye of the Scotty dog. So so we have to angle our C-arm in an optimum degree, so that the ear of the Scotty dog is at 2 feet distance from the margin. This is something which I found useful. So another concept, another theoretical concept is the safety triangle. The safety triangle is basically a triangle which you can see is bounded by the nerve root, the exiting nerve root, the pedicle, and the lateral border of the vertebral body. So this is the safety triangle. The safety triangle doesn't have any neural structures. So if you're aiming your needle to be in the safety triangle for your transfemoral injections, nerve root blocks, the patient won't feel the pinch while you're putting in the needle. The patient won't wince with pain when you hit because you're not hitting the nerve root. And but at the same time, this is the injection that you put in is very effective. It gives the same results even if you're hitting the nerve root. I mean, it gives the same results as both the procedures. This is another thing. And let's come to Cambine's triangle. So Cambine's triangle is basically a triangle which is bound by the hypotenuse is formed by the exiting nerve root. The base is formed by the superior border of the inferior vertebral body, and and this part, the other arm, is formed by the traversing nerve root or the thecal sac. So this is Cambine's triangle, as you can see, is bounded by two neural structures. The medially is the traversing nerve root, the laterally is the exiting nerve root, and you've got the vertebral body in between. So if you aim your needle to be in this space, you're basically in between two neural structures. And this space is also devoid of any neural structures, but your needle will be in between two neural structures, the exiting nerve root as well as the traversing nerve root. So this is something important, Cambine's triangle. So this diagram again demonstrates the subpedicular approach and the Cambine's triangle approach. So this area between the exiting nerve root and the traversing nerve root is the Cambine's triangle. And for L5, so if you inject in this region, your local anesthetic agent will be able to affect the L5 as well as the L4 nerve root. And if you are doing a subpedicular approach for the L5 nerve root, so then you have to inject your local anesthetic agent at this region, which is possibly the safety triangle, the triangle between the nerve root and the lateral border of the vertebral body. Sorry, I'm very sorry. The lateral border of the vertebral body and the inferior part of the pedicle. So this is basically the safety triangle region. This is the Cambine's triangle region. So these two anatomical landmarks, if you can identify in the X-ray, in the fluoroscopy, and if you get your C-arm aligned very well, so that you can see all these landmarks, then all you have to do is just put your needle in the desired space. Right. So here is a picture of the Cambine's triangle block. I'm not going into details. So let's come to lumbar facet joints. Lumbar facet joints. So like again, we have to like most of us prefer an oblique view to get the lumbar facet joint. So what we are aiming at in this kind of a thing is we are aiming for the medial branch of the dorsal root ganglion. So there are some people also do an intra-articular injection of the lumbar facet joints. So either you're aiming for the medial branch or you're aiming for the intra-articular injection. Whatever it is, the idea is to identify the landmarks in the X-ray, get your C-arms aligned well, so that you can see the joint well. You can identify the structures. You can see your Scotty dog well again. So let us see this picture. Suppose we are aiming for the L3 L4 facet joint, which is supplied by the L3 medial branch of the L3 dorsal root ganglion. So if you see here, the L3 dorsal root ganglion is exiting here, and the medial branch is is going down here. So if you are targeting this medial branch, so your needle position will have to be over this green dot. This is your position for targeting the medial branch. And further, if you're doing a rhizolysis, you can aim for rhizolysis of this region. And also the facet joint will be medial to it. So let us see again for the Scotty dog, where this is again a view of the Scotty dog. So if you are aiming for this is a facet joint can be very well seen. You can target the facet joint for an intra-articular injection, or if you are aiming for the medial branch of the dorsal root ganglion, what you have to do is you have to target this area, which is the junction between the ear and the nose of the Scotty dog. So it is just above the eye of the Scotty dog. This region will be your target. So you have to get a very good view of this region and target your needle accordingly. So for L1 to L4 medial branches, the target needle destination is the junction of the superior articular process and the transverse process, where the target nerve crosses the midway between the superior border of the transverse process and the mabulo-accessory ligament notch. So this MAL notch has been emphasized in many of the literature, but it's very difficult to clinically identify it or go for it. So the clinical tip is to identify the ear as well as the nose of the Scotty dog and go for that region, or identify the pedicle and go superiorly. So this is often described as the superior to the eye of the Scotty dog. So for the L5 dorsal ramus, the target point is located in the middle of the base of the superior articular process and therefore slightly below the sacroiliac. And if the iliac crest interferes with the placement of the needle at L5 dorsal ramus, you have to oblique the fluoroscope 5 to 10 degrees back towards the anterior posterior to visualize a non-obstructed trajectory to the junction of the superior articular process and the sacroiliac. So you have to for blocking the L5 dorsal medial branch, you have to move your if you're targeting for the L5S1 joint, you have to move your fluoroscope like your C-arm accordingly to go for that region. So again, this is what the operators have done is they have targeted the joint. They've gone inside the joint and put in an intra-articular injection. Some people use this also. Let's come to the sacroiliac joint. Basically, the sacroiliac joint, the anatomy, it is curved. The posterior aspect of the joint is located medially compared to the anterior part. So this gives a very complex structure to the joint when you're trying to inject it. So you cannot. So for practical purposes, only for injecting, we have to target the lower part of the joint. We have to target the lower part since we are trying to gain access to the joint from the posterior side, from the back. We have to target the lower part of the joint, and we have to angle cephalad also, because by doing that we can see the posterior part of the caudal end separately from the rest. So we have to target the lower part of the joint. We have to angle cephalad, and we have the starting point on the skin would be a bit below where the lower part of the joint ends. And you have to angle your beams cephalad in direction so that you can go in the cephalad direction with your needle as well. So this is the region where this is the region where you have to target the lower part of the joint. The beam should be directed in the cephalad direction. You can see the lower part of the joint very well, and from the posterior part, since it opens up. And this is how the joint has been breached. And when you go in, you put in dyes and put your local anesthetic agent. So for sacrococcygeal joint is something which I haven't used in my clinical practice or haven't seen, but this is something which I try to find out what sacrococcygeal joint injections are. Sacrococcygeal joint is a fibrocartilaginous joint between sacrum and coccyx. It is supported by anterior posterior sacrococcygeal ligament, which are very tough ligaments, and between the coccyx 1 and 2 segment there is often a vestigial disc, which can be a source of post-traumatic hypermobility. So this is what the injection, what the techniques have been described is you put the patient prone on a table, get the legs abducted so that you can so that the gluteal muscles get out of the way, and you get a clearer picture with your C-arm. With AP view, you can see the sacrococcygeal disc space, and you can and again with the lateral view, you can with an AP and lateral view, you can target your localize your target and go in with a needle and put your injections. But some people do it with ultrasound guidance also, which I think is more popular than X-ray guidance. So I put in a picture of the sacropoccygeal joint with how it looks in the ultrasound, although it's not included in this topic. And some people do this ganglion impar block. I don't have any personal experience with this. So the ganglion impar can also be targeted using a fluoroscope, and this helps in coccydynia pain, according to many literatures. Thank you for your patient hearing. I'm open for any discussions.
Thank you, Anindo, for the excellent talk. We will take the question and answer later part of the session. Now I will invite Dr. Shumayo Datta. Shumayo Datta is going to talk on neural innervation of the.
Oh, yeah, Anindo, you have to undo your screen share because I can't screen share till you're on.
Stop share. There you go.
Okay. Okay. Okay, so today I'll be talking about the neural innervation of the facet joint, sacroiliac joints, the ganglion impar, and the nerve root orientation in the neural foramina. So where there's a joint, there's movement. Where there's movement, there's degeneration, and where there's degeneration, there's pain. And the facet joint and low back pain have been associated with each other very closely. It's been estimated that the facet joint pathology is contributory in 15 to 50% of patients with chronic low back pain. So it does play a big role. But exclusive facet joint pain causing the low back pain is as low as 4%. And the rates of facet arthrosis in the general population is around 57% between 20 and 29 years of age, above 90% between 40 and 49, and around 100% by the time someone's 60, and most of which happens at L45. So it's a very common condition. And why is it painful? It's painful because the capsule and the synovial folds inside the joint both possess nociceptive nerve endings. So the substance P nerve fibers that have been identified in the subchondral bone in the degenerative lumbar facet joint also. And inflammatory mediators such as prostaglandins and cytokines have been found in these cases. So if you look at the innervation of the facet joint, so there's a spinal cord, the thecal sac, the nerve root comes out, it gives a ventral branch and gives a dorsal branch out. So if you look at the first image, the dorsal branch will then go on to give 3 branches, a lateral, intermediate, and a medial branch. So the medial branch will hug the facet joint, and then it supplies the facet joint, and then it continues to go on and supply the multifidus. So that's looking at it from an axial view. If you look at it from a sagittal view, you would see the neural foramina, the nerve root coming out from the foramina, and then it goes on to give a ventral branch and a dorsal branch, and the dorsal branch would give a medial branch. So looking at just the medial branch, so once the medial branch has come out from the dorsal branch, there's a medial, intermediate, and lateral branch, all of these supplying the muscles at the back and the joint, facet joint. The medial branch, it comes out and supplies the facet joint, but it also receives a branch from the medial branch of the joint superior. So both of these together combine and supply the facet joint. Next, coming to the sacroiliac joint. So a few interesting parts about the sacroiliac joint. It's unique in the sense that its articular surface has multiple ridges and depressions that develop and deepen over one's lifetime. During the natural maturation process, the morphology and characteristics of the SI joint will change. And the joint surface is relatively flat in earlier life, allowing for a good amount of movement in all directions. But however, as life progresses in the second and third decade, the joint surface will now develop distinct angulations, and that flat smoothness it's going to lose. This in turn will help the two bones lock in with each other and give functional stability. So if you look at the sacroiliac joint, if you look at the whole sacrum, you'll see the sacroiliac joint will be covering just the upper half of the whole sacrum. And the upper half of the sacrum will correspond to the L5, S1, and S2 foramina. So then you would logically come to the conclusion that the nerve supply of the sacroiliac joint would be from the dorsal rami of the L5 to S2 nerve roots. But the nerve supply, it's a very highly innervated joint. So from the back, it gets its nerve supply from L5, S1, and S2 from the dorsal rami of these nerve roots. Sometimes S3 can also contribute, but never does S4 come, and sometimes you have L4 also sending down a branch. But the nerves are there also anterior to it, and they will also participate in supplying the SI joint. So the ventral rami of L4, here seen as a dot here, the ventral rami of L4, L5, and the superior gluteal nerve, these will give branches into the sacroiliac joint from the front. The ganglion impar, it's an irregular shaped terminal ganglion that's formed by the combination of the two sympathetic chains, and it's usually located in the midline. So it's variable shaped. You can be almost 4 millimeters to 5 millimeters long, and it's found on the anterior surface of the sacrococcygeal joint. So here you see that in the image that the sympathetic trunk is coming down on both the sides, and then they will combine here. This is the sacrum coccyx. So around that joint, they generally combine and form the ganglion impar. So why is the ganglion impar important? It's important because it gives the sympathetic innervation to the perineum and relief of perineum pain by giving a ganglion impar block was described first by Plancarte in 1990. So we usually use this for coccydynia now. This is a case on such. I generally avoid this procedure, but if a patient requires a surgery for any other reason and has this coccyx pain also, you can do it. So there you see the needle going in through the sacrococcygeal joint, and a dye injection is going into that area, and you see the dye moving along the ganglion impar, and then you give the anesthesia. And coming to the final topic, which is the nerve root orientation in the foramina. So if you look, looking at the foramina, we all know that the foramina has either inverted teardrop appearance, or when you look at it on the parasagittal images of the MRI scan, it gives you a keyhole image. So a keyhole which is wider and more round on the top and thinner down at the bottom. So this is the foramina. So the foramina, if you break the spine up into its different parts, so you have a central part which is marked by 1, 2 is the paracentral part, 3 is the foraminal part, and 4 is the extraforaminal part. The third foraminal part is where the pedicle is, so it's above and below the pedicle. Now we all know that the foramina is primarily occupied by the nerve root, but apart from the nerve root, there are many structures there, all structures of importance. There's the nerve root, the sinovertebral nerves, sympathetic fibers, intervertebral arteries and veins, small lymphatics, fatty areolar tissue, and foraminal ligaments. So a lot of structure there. And the nerve root is generally oriented in the superior part of the neural foramina, as shown in this picture. So here you see the keyhole appearance, the disc in front, ligamentum flavum at the back, the joint here, the superior articular and inferior articular process. And you see the nerve root is located at the top of it. And above it is the inferior notch of the superior pedicle. Below it is the superior notch of the inferior pedicle. Anterior to it is the vertebral body, posterior to it is the joint. And there's the disc just below it, flava at the back. So it occupies around 35% of the foramen's diameter. If you go higher in the lumbar spine, it occupies lesser because the foraminas are larger there. If you go lower, it occupies more. So the foraminal height would generally vary between 20 and 23 millimeters. The width is around 8 to 10 millimeters. The nerve root is held in this place by multiple ligaments. There are around 5 ligaments in this area that go from the disc to the superior part of the facet joint, interligaments that connect the nerve root to the pedicle, and it basically creates a channel through which the nerve goes through. And you have to understand that the neural foramina is a very variable changing structure, because when a patient moves, flex, extends, the foramina will change its height and diameter. Based on a person's disc height, the foramina will change its diameter. Osteophytes there influence the foramina's diameter, so it's very variable. When a person will flex, like in lumbar flexion, there's a 12% increase in the neural foraminal area. And when a person extends, there is around a 15% decrease in the foraminal area. So that has been studied. These are all studies published in Spine. So there are two types of foraminal stenosis that you get that influence the nerve root orientation in the foramina, and I'd like to cover a little bit on both of them. So one is a transverse stenosis. So what is a transverse stenosis is basically when the disc height is maintained. So the disc height is not the problem. So that you can have a disc bulge there or a herniation there, pushing the root, on the root and causing symptoms. Or at the back, you can have a ligamentum flavum hypertrophy causing antero-posterior stenosis in the foramina. And that's one type of foraminal stenosis. And the other type of foraminal stenosis is vertical stenosis. So in this, what happens is the patient will lose disc height, and this disc will then flatten out, causing this superior articular process to push up into that foraminal canal and then result in a squeeze of the nerve root space. So these are two very clinically important points. And with that, I conclude my talk on the nerve root orientation in the foramina and the innervations of these joints.
Thank you, Dr. Shamir. It was a very good talk. We will take the question answer and at the end of the session.
Yeah, thank you, sir.
Okay. So now I'm going to give a talk on ganglion impar anatomy, ganglion impar block, techniques, indications, contraindication, and complications. So a little bit about the anatomy of the ganglion impar. Basically, there are two sympathetic ganglion, a pair of sympathetic, a chain of sympathetic ganglion on each side of the vertebral column. And as you go down from top to bottom, they come to a single point in front of sacrococcygeal junction, and that is called ganglion impar. Impar means single. It is in fact, it is the only unpaired autonomic ganglion in the body, and it marks the end of the two sympathetic chains. It is, as you know, located in the retroperitoneal space, just anterior to the sacrococcygeal joint, and in some patients, in large number of patients, is present anterior to the first and second sacral vertebrae. So the location is anterior to the sacrococcygeal junction, in front of first and second coccygeal vertebrae. And what is the importance of this ganglion? Basically, this ganglion, it receives afferent pain fibers from the perineum, rectum, anus, distal part of the urethra, vulva, and distal third of the vagina. So if there is a problem in any of these anatomical structures, if it is a chronic problem which is not responding to the normal treatment, pharmacological treatment, then you may consider these patients for this sort of ganglion impar blockade. The first time the ganglion impar blockade was described by Plaquette in 1919. He took 16 patients. From all these patients, they were suffering from cervical, colon, endometrial, rectal, or bladder cancers, and they had no response to pharmacotherapy. And it was a neurolytic ganglion impar block. In around 50% of the patient, he had 100% pain relief, and next 60 to 90% of the patient, they have next 8 patients, they had 60 to 90% of the pain relief. So now coming to the indication of ganglion impar block, basically is a chronic pain which is arising from the genital, anal, visceral, or perineal region. As I said, the afferent which is coming from the perineum, distal rectus, anus, urethra, vagina, vulva, coccyx, and scrotum. So if there's a chronic intractable sympathetic discomfort in this region, you can try ganglion impar block. There's a whole list of gamut of this thing indications: perineal pain, proctitis, vulvodynia, scrotal pain, vaginal pain, complex regional pain syndrome, endometriosis. Most commonly, what we use it for post-traumatic coccydogynias or Feldback syndrome. It can also be used in proctalgia fugax, that is the involuntary spasm of the rectal muscles, radiation proctitis, post-herpetic neuralgias, etc. Contraindications are, there are no absolute contraindication. Basically, it is a local skin or subcutaneous infection, sacral abscess, spondylodiscitis, or bleeding disorders. The 3 types of techniques which have been described, one is the lateral position, second is the lithotomy position, but most commonly nowadays, what we use is the prone position. We can use, commonly what we use in our studies is the fluoroscopy, but it can also be done under CT and ultrasound guided distinct techniques. So these are examples of the CT guided, ganglion block. And this is the ultrasound guided. Basically, this is the cornua, sacral hiatus, at the end of sacral hiatus. If there's a prominence there and where the injection is given, the disadvantage is that you have to confirm the needle placement again by the C-arm. So commonly what we use is the C-arm guided ganglion impar block. There are various types of approaches which has been described. The original approach was trans-anococcygeal. That is what the placard used. He went between the anus and the terminal part of the coccyx. There's a ligament, and he used a bent needle. This was a bent needle technique, which was later on modified by Nabab, and he used a curved needle. The problem of this technique was that you have to keep one of your finger inside the rectum to see whether the needle is perforating the rectum or not, and it was done in the lateral position. It was quite uncomfortable for the patient, and there was some chances of this needle getting broken and perforation of the rectum. So all these approaches were further modified, and nowadays most commonly it are the trans-sacrococcygeal, transcoccygeal or paramedian approaches which are being used. So this was the original trans-anococcygeal approach, in which the curved needle was used through this anococcygeal ligament. It had the problem of they had technical problems. There were anal perforation injury to the vessels, and failure rate was quite high. So all these approaches were later on modified, and these transcoccygeal approaches were used, and they were simple. They were direct approaches. They used to have the small needle, and less amount of medication is required in these approaches. There's no needle breakage, and there are minimal complications in these approaches. There's a disc between the sacrococcyx and the C1, C2, and C3. That you cannot go through transcoccyx, and then you have to modify the approach, and that approach is paracoccygeal approaches, in which you use a needle which is bent, and then you slide around the vertebral bone, and inject then you tilt it slightly medially, and then you inject your all the injectable material there. The technique is very simple. You have to place a pillow beneath the pelvis to make the coccyx more acceptable. You can use two types of technique. One is the needle within the needle technique, or second technique is the direct needle technique. You may inject ropivacaine and bupivacaine followed by contrast dye, and in coccydodynia you can initially try Kenacort or dipomedrol. But if you are doing ablation of the ganglion, then you can use phenol or absolute alcohol. And some people, they use radiofrequency ablation probe also for chronic discomfort. So this is the basic thing. First you take an 18 gauge needle, and through that 18 gauge needle you can use a second needle. Once the needle the tip has just appeared on the lateral view in the C-arm, you stop at that time, and then you inject the dye around 1 ml or contrast medium, and you will see this sort of the reverse, which is called so-called reverse coma sign, indicating the localization of the ganglion. And once you localize that ganglion, then you inject the either Kenacort or you wait for some time and then inject the absolute alcohol around 1 to 2 ml. So there's a video there, a small video of 1 minute duration. So basically, this is the positioning of the patient. You place a pillow beneath the pelvis and localize the area, infiltrate the area, this thing, periosteum with the 2% xylocaine. Put your needle there, orient the needle along the sacrococcygeal junction in the disc region, and pass your needle through this disc space. Once you are in front of this, just 1 to 2 millimeter in front of the disc, you check it, check the position in both EP and the lateral view. Once you check the position, then you take 1 ml dye and inject the dye very carefully. Don't go too far, and you can see the ganglion there. Once you've seen the ganglion, then you can inject whatever you want to inject. You can inject some xylocaine or this thing, ropivacaine, and along with the Kenacort or the dipomedrol. For long-term relief, you can do the chemoablation either with the alcohol or the phenol, or you can use a radiofrequency ablation probe or cryoablation of this ganglion. For diagnostic and prognostic block, you use around 1 to 3 ml of the local anesthetics. Or for neurolysis of the ganglion impar, 1 to 2 ml of the neurolytic agent, such as 99% alcohol injected, usually around 20-30 minutes after the diagnostic block. There's certain, so far this procedure is with the minimal complications, but sometimes you can you have got some branches of the internal iliac artery which are in this region. You can puncture one of those arteries. You can have some bleeding there. One of the very important complications, especially which has been described with the chemoablation agents, is the migration of the either the phenol or the alcohol spiral. You see, basically, whenever you're injecting something here in this region, there's very little space for this chemicals to go down. So if you have injected very high volume, then it can go higher up, and there is a hypogastric plexus of the parasympathetic plexus, and it can interfere with the function of the parasympathetic plexus, and then it can cause the sexual bladder or bowel dysfunction. So as a precaution, you should use the minimum amount of the material, around 1 to 2 ml. And once you've injected the material, then ask the patient to lie still for 2 hours, so as to prevent the spread of these agents, chemoablative agents, higher up. If you're not careful, you can cause the bladder and bowel perforation. There are very minimum chances of discitis or local infection or abscess formation. Thank you very much. Now the session is open for the question and answer. Thank you. Any question?
So I think we've had a very excellent session. Can I ask you a question, Dr. Abrar?
Yes.
Very nice talk. So how frequently do you inject these patients? And
so basically, what we get majority of the patient, we do these things on chronic chronic coccygenetic pain, which are not responding to normal treatment. We have done the physiotherapy, everything. And in those patients, at least so far, I have injected in around 30 to 40 patients. And I have got very excellent result. But what you should rule out one thing is that this pain should not be a referred pain from the lumbosacral junction. In some patients, this pain is referred pain. In those patients, you will not get very good relief. So it's better first to give a diagnostic block. And if you just inject the local anesthesia and wait for some time, if the patient says that he has more than 50% reduction in pain, then you inject the further material there.
How frequently do you inject? It's only a single dose, or
usually I have so far given only a single dose, but it has been described in literature. You can repeat it after some time, or it is very easy to chemoablate these joints. You can just inject if the patient is getting very good response. Around 1 ml of the absolute alcohol you can inject there, and it is going to give a very lasting benefit to the patient.
Abrar sir, I have a question.
Yeah.
Very nice talk. Do you always find that there is a local tenderness present to confirm that this technique will succeed? Because you have just said there might be referred pain. So how to differentiate that it's not a referred pain?
The patient, they come with the typical history that whenever they're sitting, they're getting this pain. The moment they get up and walk around, they don't have this sort of pain. Okay. So it is a very classical history that whenever they are traveling in a bus or there is some jerky movement somewhere, or some patients, they have history of previous trauma, and somehow they develop either the decreased hypomobility or hypermobility of these joints, and then they start having this pain. So that's why it is very important initially to give some local diagnostic local anesthesia to rule out whether this pain is coming referred pain or is the pain coming from the coccyx. One thing is history that the patient, whenever walks around, he doesn't have any pain. The pain is only on the loading of the spine, and it gets relieved by the local anesthesia.
Does angulation of the coccyx has any correlation with?
No, angulation has no correlation. Basically, the angulation is the God-given angulation. If your coccyx is vertical, you will not be able to sit on that coccyx. So it's the natural curvature of the coccyx, and it has been described into various different types, but it has no correlation with the coccydynia.
Thank you.
Question to Dr. Ahmed is, along with the fluoroscopic guide, do you use the tactile sense so that you can assess whether the needle has perforated the disc? And
no, see, the thing is that you have to check that thing in both CM, in the AP and the lateral view. Okay. Once you have injected once the tip of the needle is just visible in the lateral view, You take an AP view, angle your CM in the 10 degrees separate direction, and you'll be able to see whether you are exactly in the center or not. And that is not important. Second thing is that even if it is the joint is fused, you can go through the paracoccygeal approach also from both the sides, curving the needles. Okay, just slide over the bone.
Okay.
And inject the dye there. So it is very difficult to perforate the rectum there, because there's a layer of fat around this area. So the one approach of fusion was described. Transaxial approach. People do not do that thing.
Obsolete because of the rate of infection is high, but
because they are going just very near to the rectum.
I have a question.
Yeah.
Yeah. So how many of us are actually doing a lumbar facet block? I mean, I know we are going to go into that later on again, but since Anindo had been covering that, like how many of us give lumbar facet blocks for degenerative spine?
I think majority of the people they're doing it. Majority of the people.
So we'll get to hear more on that, like the efficacy of that.
The problem is that initially we used to refer this patient to the pain specialist. The problem is that these people do not go to the pain specialist. So that's the big problem. They're not very much satisfied. If you give a block yourself, probably the satisfaction rate is much better. So nowadays, for radio frequency ablation and other things, I refer those patients to the pain specialist. Any other question? So I will hand over the. So Basu, should we start the next session?
I think we should start the second session with Dr. Rai chairing the session.
Dr. Rai is chairing the session. Dr. Rai, please, sir.
Hello, am I audible?
Yeah.
Yes, you have to turn on your video, sir.
Yeah, I'm having a little net problem, but then I'll try again. I don't know if, yeah.
At least, yeah, you're visible, sir.
Thank you very much. Good evening, everybody. We've had a wonderful session so long. My only problem is that because of the net problem, I don't have the list in front of me. I wish could Shomujit or maybe Dr. Abrar could share the list of the speakers.
Dr. Abrar, could you call in the speakers one by one?
Yeah, the first speaker is Dr. Subrato Goswami. Dr. Subrato Goswami, as you know, is a very famous person, is a very famous, pain specialist. He is going to talk on cervical epidural, root blocks, indication techniques, contraindications, and he will present a small video. Dr. Subrato Goswami, please, sir. You're not audible, sir. You switch on your this thing.
Dr. Goswami, we can't hear you.
You switch on your audio.
Sir, please unmute yourself. Sir, please unmute yourself.
Dr. Goswami, could you kindly unmute?
Yes, now I think I am audible. Now I think you can hear me.
Yes.
Hello.
Yes, please start from your first slide. Dr. Goswami, please start from your first slide again.
Yes. I have to. Yes. So my topic on cervical epidurals and the root blocks. But nowadays, going to more complications on particularly the root blocks and the transforaminals, the global shift has been there towards the cervical epidural only. And very few people, even I have personal communication with Gabor Rax, he has also stopped doing these transforaminal root blocks because there are many segmental arteries and which are going through the intervertebral foramen, and there are many complications and injuries nowadays. So I will try to limit my discussion on cervical epidural injection only. Now, we know that some special features I will talk. One thing is to be remembered in the posterior part in the cervical spine, sometimes there is no ligamentum flavum. So practically a midline epidural is not to be done, because often the first loss of resistance we get after piercing the dura and after going into the interthecal space. So that is one important thing. We know the boundary. I'm not going details into it. Behind is the ligamentum flavum, and in front is the dura. And this is the cervical epidural, and the posteriorly and anteriorly is the anterior longitudinal ligament is anteriorly. Laterally, the vertebral pedicles and the joint capsule and the intervertebral foramen. What I talked earlier also, that the ligamentum flavum in the cervical region is relatively thin, inconsistent, sometimes deficient, and it has got contents of fat, veins, and arteries. Another important thing is to consider the distance between the ligamentum flavum and the dura is at the level of the C7 and T1 is 1.5 to 2 mm only. So in the erect posture, there is only hardly a space to put a needle inside it. But if the patient, the neck is flexed, then this distance reached. So better to avoid cervical epidural in sitting position. And the indications are cervical radicular pain syndromes, disc herniations, traumas, spinal stenosis, herpes, and post-herpetic neuralgia. But we have to remember that only if there is no motor weakness, that is the effect of the pressure, motor weakness or sensory loss, and only in the pain due to inflammations, neuroinflammations, we have to see those cases only. And another thing is that in the acute phase only, it acts better. And a limitation is that it has a short lasting. It is not a long duration like that. It may last for maybe a few months or not, or like that. Some anesthetists have started anesthesia, but it has been criticized. Anyway, contraindication is a pre-cervical spine injury, and because in cervical injury there is a lot of and venous pressure. So the veins are engorged. There is injury to the veins causing to hematoma, and the spread of the drug is also very difficult in the fibrosis. And if one cannot see the fluoroscopy visualization, particularly in the lateral view, most of them collapse and other. So common case is C7 player, actually it is very difficult. So sometimes we go for swimmer's view also. The techniques that equipments are to handle, and is the epidural needle. But at the start, so the wax acute to needle is preferred when it is blunt tip, and so it is to be. Otherwise, the patient.
Sir, you are not audible.
Goswami sir, we have lost your presentation as well as voice.
Yes,
Sir, can you rejoin?
On the contraindication slide, Dr. Goswami, you're on the contraindication slide, and you're totally inaudible. We can't hear you.
Sir, I think there is a network issue.
Yeah, I think I was having it a little while ago. We can now see Dr. Anindo having his evening snacks. But
Sir, can we move to the next presenter?
The next.
Shall we? Is Dr. Goswami? Can you hear me?
Hello.
Dr.
Dr.
Goswami, are
Goswami
you
just Dr. Goswami just rang me up.
Hmm.
He's finding a little bit difficult to rejoin straight away, so he wants the next lecture to be started so that he can join in again, take the rest of the lecture.
Okay.
So that should be Dr. Noskar, Dr. Shushmit Noskar.
Yes, yes.
Dr. Shushmit Noskar, are you there? Are you
Yeah,
ready?
yeah. Am I audible?
Yes.
You're audible.
Yeah.
Are you ready with your presentation?
Yeah, I can share my
Then please
screen.
share screen.
Yeah. Good evening, everyone. Thank you for this offbeat topic. Today, I'll be talking about intercostal nerve block, its indications, contraindications, anatomy, and a short video technique. Intercostal nerve blocks is effective as primary pain management modality or in conjunction with thoracic surgery for chest wall and upper abdominal pain. There is a lot of overlap between specialties, pain specialists, spine surgeons, thoracic surgeons, all proceed with this technique. The indications are incisional pain from thoracic surgery, analgesia for thoracostomy, herpes zoster infection, rib fractures, breast surgery, upper abdominal surgery. It can be used as a diagnostic modality to differentiate between visceral and somatic pain. In a spine surgeon's practice, it is most commonly used for a far lateral thoracic disc prolapse with only radicular symptoms where the patient doesn't want to go ahead with the surgery. Contraindications are few. Absolute contraindication is patient refusal and active infection at the injection site. Allergy to local anesthetics, prior nerve injury, and coagulopathy are few relative contraindications. Like any other procedure, to know the anatomy well is very much pertinent to this procedure. So 12 pair of thoracic nerve roots give rise to 12 pair of intercostal nerves. Immediately after the foramen, they divide into dorsal rootlet that supplies the paraspinal muscles and skin over it, and a ventral rootlet that continue as a intercostal nerve along the costal groove of the same rib. It divides in a mid-axillary line, gives a muscular branch at that level, and it travels anteriorly. Again, it divides into a medial and lateral branches, and it anastomoses with opposite side intercostal nerve. Effectively, this intercostal nerve is responsible for sensory supply to whole trunk, back, anterior chest wall, and upper abdominal wall. So the muscle layer in the intercostal spaces are external intercostal, then internal intercostal, and the innermost intercostal. The nerve travels in a neurovascular bundle along with intercostal vein, artery, and nerve. Nerve being the bottommost, and they remain in innermost and internal intercostal groove. As they are in a neurovascular bundle, that's why there is high uptake of local anesthetic agent. Coming to the surgical technique, we have more easier, less resource intensive fluoroscopic guided technique, and pain specialists mainly used ultrasound guided technique. This is more accurate. There is less chance of intravascular injection and less chance of pneumothorax, as you can directly visualize the nerve. And you can direct for more medial injection that will allow a dorsal branch block as well, giving complete anesthesia to that dermatome. I'll go ahead with a demonstration video of a fluoroscopy guided technique. I'll just share my technique here. The position is prone in my case. The patient should be attached with pulse oximetry, ECG leads, and BP cuff. A physician anesthetist standby is preferable in the setting of unfortunate complications of pneumothorax. Patient lies on parallel pillows on the chest wall, and we'll confirm the level either counting from 12th rib upwards or by fluoroscopy. At upper thoracic levels, scapula and medial muscles come in the way of intercostal groove. It is difficult to palpate the intercostal groove at this level. So dangling of both the upper limb from the side of the table will retract the scapula, and that will help locate the intercostal groove. We mark the sinus process that helps to measure the distance of our injection. At upper thoracic level, D1 to D6, the rib angle usually lies 4 to 6 centimeter lateral to midline, and at lower thoracic level, D7 to D12, it is about 6 to 8 centimeter lateral. In our technique, after standard skin preparation, level is marked in an AP fluoroscope. The artery tip can be marked as a metal marker, and the lower edge of the intended rib is marked. A 22G spinal needle is introduced at inferior edge of the rib with a 20-degree cephalad angulation. Various authors describe minute variations in techniques for this needle introduction. Some pull the skin upward and introduce the needle at the middle of the rib and then leave it so that the needle retract with the skin inferiorwards. Or you can directly hit the inferior edge of the rib with your needle, then walk on the inferior edge and dip another 2 to 3 millimeter, not more than that. Be very careful at this stage because inadvertent advance of the needle may cause pneumothorax. You might feel a definite pop, that is the piercing of internal intercostalis fascia at this level. That means you are in the plane between internal intercostal and innermost intercostal. That is the space where your nerve is. A water-soluble dye may be used for confirmation, but that is not mandatory. We prefer short-acting local anesthetic agent like lignocaine because as it runs in a neurovascular bundle, there is very high uptake of local anesthetic, and a long-acting local anesthetic like bupivacaine might cause severe toxicity. For multiple rib fracture conditions, when we want to block multiple ribs, intercostal nerves, safe dose of anesthetic should be calculated beforehand. This is a small video presentation of this case. So I'm standing on the left side. So this is, I'm just advancing and I'm hitting the lower edge of the rib and tactile feeling.
This video is not playing on my screen.
Video is not playing.
Can anybody see?
Here I can see the video is playing.
No,
I don't know.
I cannot see the video.
No, we
I
cannot
don't think
see the
anybody
video.
can see the video.
Nobody can see it.
Just a minute. I'll just start it.
You have to share the video. Click on the yes.
It was running in my screen. I don't know why.
You unshare the screen, please, and then again share the screen.
Share the video separately.
Okay, I can share the video.
Share the video separately.
Yeah, I can do that. Is it visible now?
Yes. Yes.
Yeah. So you advance your needle after marking the level, and hit the lower edge of the bone rib and check it in the fluoroscopy with 20-degree approximate angulation, but that can be varied off according to your field. Then you gently slide off the inferior edge and don't advance further, like 2 to 3 millimeter more, not more than that.
Okay.
So the video, whoever is taking the video, was focusing once on me and once on the Siam. It's not very good presentation, but it's more like a field dependent, and you can confirm it with a radio opaque dye, but that's not mandatory. So I had a surgery lined up. Before that, I did the demonstration procedure. So it's only 1 to 2 ml of lignocaine has been injected. And the final. So this is the final location of that video. So nothing more. That's all. The complications are mainly pneumothorax, and sometimes there is a high uptake of the local anesthetic from the local site, and that may cause central or cardiovascular side effects of the local anesthetic agent. Thank you. Any questions? Am I audible? Hello?
Yeah, audible.
Yes, you're audible.
Yeah, okay.
Thank you, Dr. Naskar.
Yeah.
Shall we go to the next, that is Dr. Somujit's paper, or shall we go back to...
I think Dr. Subrata Goswami is back.
You can go to Somojit's, because I am having some technical problem. I do not know why. Just now I can listen to you. I can
I've just
see
got your name, Dr. Goswami.
Your
name is there on the screen.
You can see me? Okay.
I can see the name only.
So,
I can hear you.
Can you see my presentation?
No.
If you share your screen, we can.
I have already shared, but now again the Zoom button is gone. I can. Dr. Somojit, you please continue. Again, I'll tell whenever I am comfortable with this technical problem. Okay.
Right.
So I think if you have any questions,
we can take questions later. Dr. Somojit, I don't know, this net is playing up with a lot of people. I had a lot of problem in the beginning. So could you...
So is my screen visible?
Yes.
Yeah, totally.
So thanks to the organizers for asking me to talk on lumbar facet blocks and root blocks. Now, when myself and Dr. Abrar sat together in planning this program, we wanted that the first hour should be more of theoretical background to pain procedures in the spine, and the second hour, the second session, will be spent on more on technicalities. So considering that in mind, I had basically rushed through a couple of slides to show you a couple of examples, basically one of lumbar facet block and the other of lumbar root block, and then go on to a small clipping of a video. I have a voice in that video, so I just want to retain the voice, because it being a provocative procedure, you can listen to the patient's voice. There are a little bit of interruptions in the video, and there is a background noise. It was very hurriedly shot. I beg your pardon for that. So as we know, in the armamentarium of the spine surgeon, facet joint blocks, selective nerve root blocks, epidural steroids, sacroiliac joint injections, and the ganglion impar blocks are the typical sort of injections that we do encounter. Rarely do we do pars block and discography, and these are mainly for diagnostic purposes. The others are more for therapeutic, as well as occasionally when we get stuck to isolating the pain generator, we have to rely on these procedures. I'll just share with you a couple of slides on facet joint injections, because Dr. Abrar asked me to cover that also. This is, as Abhishek pointed out, it's not a very commonly practiced procedure, but just for the completeness of the talk, it is helpful when the pain generator is the facet joint. And as we all know, facetal pain occurs in extension, discogenic pain occurs more in flexion. Anything between 15%, as Shomayo quoted, it is about 15 to 30% of patients has facetal involvement, and many of them have a facetal involvement not in isolation. They also have additional ligamentous, discogenic back pain incorporated, so it's very difficult to isolate those patients who have only facetal pain. CT and bone scan, especially the SPECT scan, picks it up very well, and these are the standard medications. Typically, bilateral 4-5-5-1 joints are injected. Now, as you know, these are the positions. I will not go into the details of these, and I'll share with you a typical oblique view, which the Scotty dog view, which Anindo so beautifully explained to us a while ago. And that is the area of the facet joint, which you see if you properly angulate your C-arm so that you can see it right away end on. As you can see, this is the facet. And this is a patient who actually came to us with a unilateral pointing localized back pain. I don't know, I might have got only 2 or 3 such in my 16-year career as a full-time spine surgeon now. And this is an isolated degeneration of the facet joint. Initially, we thought it could be infective. The CRP was normal. There were no other inflammatory markers. History-wise, also, she did not have anything suggestive of an infection. And as you can see on the SPECT scan, there is a bright spot only on that area, and that is the point where we injected. So this is a patient with an isolated facetal pain, matching with the CT scan, as well as the MRI, as well as the bone scan, the SPECT scan, and this is a patient we injected on one facet only. And a typical facet joint would involve bilateral 4-5-5-1, but in this patient, as there was unilateral pain with one facet joint being the pain generator, this was a good diagnostic purposes. We did inject her thrice, and she got quite a good relief of pain. Going on to selective nerve root blocks, it is usually used when pain generates the nerve root. Root pain occurs in extension or flexion, depending on whether it's PID or stenosis, and typically has a radicular distribution. I love the presentation of Shomayo when he showed us that the root, and he correctly showed us the pictures in which you can understand whether the root is an up-down stenosed root or a front-back stenosed root. And for the young generation of spine surgeons, it's extremely important for them to realize that when it's an up-down stenosis, your surgical aim not only is to decompress the nerve, but also maintain the disc height. Whereas if it is more of a front-back stenosis, if you take out the facet joint and deroof the root completely, even without a cage or even without a disc space distracting device into the disc space, you can get away with it. And as you know, MRI scanning should be done with the parasagittal cuts in the both sides, as well as the axial cuts, and typically unilateral L4 or L5 or S1 which are injected. And this is the lateral view. It was multiply repeated in the last few lectures. So if this is the lateral view, the needle should come just a millimeter short of the posterior vertebral border. And as you can see, this is the pedicle. The needle has to come to a very close proximity to the posterior border because the root comes out there. And from the anteroposterior view, you can see that it just is about a millimeter below the lower end of the pedicle. Remember that the disc spaces and the end plates should be seen very well. The end plates should be sharply outlined. The C-arm should be placed in such a way, such a lordosis, that the disc spaces are absolutely staring at you. And this is the oblique view in which you can see that if this is the pedicle and this is the neck of the Scotty dog, there is where you inject. This is where you inject. This is L5. So this is an L5 root block in which you can see this is the L5 pedicle, and that is where the needle goes in. That's how it looks on the AP view. It's the L4 and the L5 root block. And if you can look carefully, that's where the needle ends. That's where the needle ends, just a millimeter short of the vertebral body. So I'll show you a small presentation of a video. I just hope it works. The joint shown as two Is the voice audible?
Voice.
The joint
We
of
can't
the
tell you.
articular process.
We don't see anything.
Also note that you can see the disc faces.
I'll just unshare and then again share.
Again, the video is not coming here.
Is it working now?
Yeah.
Yes. Yes, you're there. You can see.
This is the point of approach for the L5 root.
Is the voice audible?
Just you can go there underneath the eye, that is underneath the pedicle of L5, and just lateral to the neck, which is lateral to the pulse.
There's a bit of background noise. I'm sorry for that.
Virtually dead AP, if not a little bit of kyphosis so far as the CR is concerned. So not and show the position of the CR. And the obliquity is much reduced. So when you try to show the response parameter, make sure that the obliquity is less. And the lordosis is absolutely straightened out, if not a slight bit of kyphosis. Now if I put the needle here, that is where the position of the S1 foramen is. This is actually the posterior sacral foramen through which you can reach the S1 nerve. So in this particular X-ray, which is about 10 to 15 degrees oblique, not much, this is the end-on view of the sacral pedicle. Now, I wish to state here that the S1 pedicle is very highly variant anatomically. Various people have various types and various positions of the S1 pedicle. This is very variable. So you must adjust the CR picture accordingly so that you have an end-on view of the S1 pedicle. And the posterior foramen of the S1, through which actually no important structure comes out other than some emissary veins, that is the position of the S1 foramen, posterior foramen. And the superlateral aspect of this, that is the point of target of the S1 root block. Because the S1 root moves like something like this and goes and exits out of the sacral bone to the anterior sacral foramen, which is actually this. But here is where you would be targeting for the posterior sacral foramen. Point to be noted is that the entry point of the sacral foramen is much medial to the entry point of the L5 foramen, L5 root block. Appreciate this. কোথায় লাগে? ঠিক আছে, এবারে কমে গেল? কমে গেল? So as you can see, we got a provocative response. And I'm going to take a lateral shot to show you where the exact position. Now you can see that I'm adjusting the amount which I need to go in. See, now I'm just about a millimeter downstairs of the lower end of the pedicle, and I'm just touching the frontal bone very near the pedicle. This is the position of the root. So along with this, the provocative response of the patient tells me that I am actually very, very close to the L5 rooting point. Just I am lateral to the posterior foramen. This lateral edge of the posterior foramen as marked on the skin. This is quite a subcutaneous area, so you do not have to take the tip of the needle very far lateral. And then you can just put it in. And as the first bone strikes my needle, I take a shot. So I am a little bit caudal. I need to direct it penny and close. Now I see I can get the loss of resistance and it goes down. Now I take a shot and you see I am docked on the posterior foramen. That it has gone down, as you can check by the amount of needle which is protruding out. দেখুন দাঁড়ান, আর লাগবে না, দাঁড়ান দেখুন, এখন লাগছে না তো, পায়ে লাগলে বলবেন। So I have just entered into the foramen. As you can see, it's on the superlateral aspect of the posterior foramen. And now as I trace, she should have a response of the pain. ভয় লাগছে? ঠিক আছে, জোরে বলুন। ঠিক আছে। So that's the problem. Now I take a lateral shot. As you can see, the needle has gone into the sacral foramen and it is just touching the posterior aspect of S2. So this is the pedicle of S1. That's the S1. And through this area, approximately through here, the anterior sacral foramen, the S1 root comes out. And you've taken the S1 root there. So this is the L5 root block, this is the S1. As you can see, both of them are from lateral to medial, and they just cross the pedicle, lateral wall of the pedicle. That's the correct one.
Okay.
Thank you. Thank you. That's all I have to say.
Thank you very much, Dr. Basu. That was really informative, and I think such a interactive video with the patient also giving her responses, well shot and well done. Thank you very much. Now,
Hello.
Shall we go back to Dr. Goswami, or Dr. Goswami, do you want to come in again?
Yes, I am here. Can you hear me?
Yes.
Can you listen?
Yes, we get you loud and clear. No.
So can you see my presentation?
No, I can see you. We can see you.
But I don't know.
You have to share the screen
every time. I have shared, but
no,
I have
only you are on our screen.
Maybe it is showing that my internet connection is unstable. So sometimes it is coming and sometimes it is going. I do not know what to do. So maybe internet connection is unstable. That's what.
So maybe Devanjali can go ahead.
Go to
so
And in that case, we'll go to the next.
Yes.
If you don't mind.
Yes. I think so.
Okay, sir. Okay. Should I start?
Devanjali, yes. Dr. Devanjali Ray on epidural and caudal epidural steroids injection, contraindications, techniques, and complications. There will be a video also. Yes, Dr. Ray, please.
Thank you, sir. Good evening, everybody. It's nice to be a part of this lecture. So let's start. I'm starting with sharing the screen. Can you see?
Yes.
Okay. So my topic is epidural and caudal epidural steroid indications, contraindications, technique, and complications. So what I'm supposed to say is whether use it steroid, whether we use steroid, because it is long standing ongoing debates that whether we will use steroid or not, whether steroid is to be used very frequently. It has got so many adverse effects, whether it should be used with local anesthetic, without local anesthetic, and so many. So let's go and start some journals and meta-analysis, which is let's start with comparison of clinical efficacy of transforaminal and caudal epidural steroid injection in lumbar and lumbosacral disc herniation, which is a meta-analysis. They say that clinical benefits with transforaminal epidural steroid injection is better than caudal epidural steroid injection because it has the ability to deliver the medication directly into the target area. But the evidence is very low. So next journal is, it was published in British Medical Journal, effect of caudal epidural steroid or saline injection in chronic lumbar radiculopathy, multicentric, blinded, randomized control trial. But surprisingly, they say that caudal epidural steroid or saline injections are not recommended for chronic lumbar radiculopathy. So we will go to another paper, which is caudal epidural steroid injection to randomized control trial. They said that caudal epidural is effective because it is technically easy to give, low complications than other techniques, and So it is interestingly more demanding in case of management of low back pain and sciatica. Another study which says that the evidence for effectiveness of epidural injections in managing chronic spinal pain range from limited to strong. So they found that for lumbar radicular pain with interlaminar lumbar epidural steroid, the level of evidence was strong for short-term relief and limited for long-term. For cervical pain, the evidence was moderate, and the evidence for lumbar transforaminal epidural steroid injections for lumbar nerve root pain was strong for short-term and moderate for long-term improvement. So it has been found that the evidence for short-term relief is more than the long-term relief. So there is always a confusion how frequently we will give the steroid injection. So why for the long period we always discuss about the giving steroid? Is it a magic drug? So let's to answer this question, we have to go to the background of the degenerative disc disorder. Previously, it was said that there was imbalance between catabolic and anabolic factors, which is obsolete nowadays. So nowadays, it is said that there are some changes in the nucleus pulposus that causes the decrease in the synthesis of type 1 and 3 collagen and more in type 2 collagen and more synthesis of the type 1 and 3 collagen, also increase in the membrane metalloproteinase activity, ultimately degradation of the extracellular matrix and proteoglycans. So the integrity of the nucleus pulposus is lost, that ultimately fissure occurs in the annual ring, and the extrusion of the nucleus pulposus, generation of pain due to compression of nerves. But pain can also occur in the early stage of disc degeneration in the absence of nerve compression. Why? Because of inflammatory mediators, and that causes the the inflammatory process helps us to conclude to give steroid in degenerative disc disorder from very early stage. Now this schematic representation exactly shows what I have told just now. Due to low oxygen, low glucose, end plate calcification and some adverse load, the disruption of the disc due to changes in the structures of collagen synthesis. Now, protease, cytokines, and neurogenic and angiogenic factors, along with nerve fibers and blood vessels, are present in human degenerative discs. So, long-acting steroids is helpful. Now, I will not discuss about the cervical thoracic because it is only 6 minutes I have. So, directly I am going to the lumbar epidural indication. Radicular pain resulting from irritation and inflammation of the dorsal root ganglion and other neural structures in its vicinity. Refuse surgical correction of the disc disorders. Mainly, these two indications are there, and contraindications are significant bleeding diathesis, systemic or local infections at the procedure site, and severe degenerative changes. So, technique, I will mention about the transforaminal because we often use it in our day-to-day practice. After all those consents and stopping anticoagulants and all those, what we target is the safe triangle. So we should put our C arm first in the true epi position. Then we would try to square the vertebra by cephalic rotation of the camera. What is the squaring of the vertebra? The vertebral margin should be in line. The anterior and posterior surface should be in the line. Okay, in the single line. And then we will rotate the C arm in the ipsilateral oblique view to cover the to superimpose the transverse process with the vertebral body so that we can see the pedicle, because our target is the Scotty dog, and below the pedicle at the 6 o'clock position we would first insert the local anesthetic and subsequently the spinal needle, and we will enter the needle with the end on view with the camera of the C arm. So once we enter the space, we would change the position of the C arm and make it lateral, and we go by millimeter with the lateral view, because if we go very fast we can puncture the dura. So we will stop before a C line comes and we will apply the dye, what is iohexol or Omnipaque or whatever. So in the lateral view we will get a streak of a line, and in the anterior-posterior view, we will get a C-shaped line like that. So it is the transforaminal epidural injection. I collected some video from my institute, but due to some technical issues, I could not put it in my slides. I'm sorry for that. So next, I'm going to the caudal epidural. So see, the dural space at the caudal area is very close to the sacral bone. So we should go from downwards. We should insert our needle from the downwards and go very carefully. See the indications. It is herniations or spinal stenosis, sacral nerve root scarring, coccygodynia, rectal pain, pudendal neuralgia, sacral fracture, post-radiation sacral radiculopathy, sacral metastasis, and post-spinal surgery syndrome with pain not responding to the conservative management. The contraindications are infection, altered coagulation, first trimester of pregnancy, arachnoiditis, and etc. So, in case of caudal epidural, patient prone, pillow under the abdomen to remove the exaggerated lumbar lordosis. Fluoroscope should be in the lateral view from very first. Epi view we will see later. So we will first try to identify the sacral hiatus, because our target is the sacrococcygeal membrane that corresponds to the C2, C3, 4 vertebral junction. It varies according to the body structure. So we will proceed till the C line comes and just stop before it again in the lateral view. We will go again millimeter by millimeter to prevent the inadvertent puncture of dura. Now I will push the die, and in the lateral view same, strict a line, and in epi view it will show inverted, what is called inverted fir tree appearance. Complications are hypotension, perianal numbness, and sacral nerve root injury. Spinal cord injury due to localization of large volume of injected. See, for if we give more than 10 ml of hypertonic saline in case of caudal adhesiolysis, we may injure it. Then avascular necrosis, bladder bowel dysfunction, bleeding, hematoma. In some cases, maybe rectal injury, because all the structures are very close to each other. So I will thank my institute for the picture or images I have taken, and thank you for your patience. Have a good day.
Thank you, Dr. Ray. That was a very nice presentation.
Thank you, sir.
We can always come back with the observations and discussions later. Can we now go on?
Yes, yes, I'm now ready. Hopefully I can start.
Oh, was that Dr. Goswami?
Subrata Goswami, yes.
Yes.
But I have stopped sharing my video because I have a very poor network connection. That's why I'm only speaking. So the video is stopped. So I'll share.
Oh, okay. So we go back to our first paper really, and that is cervical epidural and root blocks, indications, techniques, contraindications. So we listen to the speaker without the video, but perhaps you could share screen and show us whatever else. Please go on.
Yes.
Dr. Subrata Goswami.
Yes. Can you see me? No. Again, there is any problem? Can you see?
We can't see your screen. You have to screen share first.
Yes, I have.
We can see nothing but your name here.
There is a blue button. I mean, green button.
No, I know. I started. I was, but I'm sorry for some reason. Thrice I have tried. I'm really sorry. My apology. My apology for my internet connection. I tried with my mobile phone also. I do not know what happened to me. So I'm really sorry, and I missed the opportunity to share my presentation. I'm sorry, sir.
So you could be available for subsequent questioning, Shubhatula.
Yes, that
while
I'm
we
available.
go on with the program.
That I'm available. That
Thank
I'm
you,
here.
because we would be. It would be wonderful if you could share us your thoughts when the questions.
Yes, I'll be till the end.
Very well then. Shall we, Dr. Goswami? Thank you. So stay with us, and I think we can go to Dr. Abhishek Ray now. Is Dr. Abhishek Ray ready?
Yes.
Abhishek,
Yes.
Dr. Abhishek, are you ready? You are. Yes, we can see you there. So we'll go to sacroiliac joint infiltration and blocks, indications, contraindications, technique, a video. Dr. Abhishek Ray.
Yeah. Can you see me? Is it visible?
Yes, sir. Yes, sir.
No.
Yes, we can hear you. Go on, please.
Yes. Give me 1 second. This is. Yeah, my apologies. Give me 1 second. This is my antivirus kicked in. Yeah. Yeah. So my topic for the day will be, so first of all, good evening, friends. And it's really regretful Dr. Goswami's presentation was one of the ones that we were looking, all of us were looking forward to. So my presentation for the evening was Sacroiliac joint injections. It's not moving. Wow. Coming to the clinical application of this, as we all know, sacroiliac dysfunction leading on to pain is a common etiology of back pain, forming about 10 to 27% of all mechanical low back pains. Patients at risk for this are mostly patients with limb length discrepancy, increased age, patients with inflammatory arthritis, pregnancy, trauma, and patients with previous spine surgeries. The indications for this particular injection, they can be given both as a diagnostic as well as a therapeutic procedure. In case of diagnostic blocks, about 75% of pain relief is generally establishes the diagnosis. And in case of therapeutic blocks, both intra-articular as well as peri-articular injections have been described. However, intra-articular injections have been found to be better efficacious. Contraindications, as usual, as for other injection procedures, relative contraindications being coagulopathy, pregnancy, systemic or local infection, and uncontrolled diabetes. Coming to the applied anatomy of the joint, as Anindo had already previously mentioned, I think Anindo as well as Shumayon. So it's an auricular-shaped diarthrodial joint having a hyaline cartilage on the sacral side and fibrocartilage on the iliac side. The innervation, it is controversial as very elicited by Shumayon. However, the pain generators are mostly the is actually enters the joint from the posterior aspect and comes from the lateral branch of the sacral dorsal rami. These are the nerves that are targeted by the injections and are blocked. So taking a transverse section of the sacral joint, we see that there is a posterior and a medial aspect of the joint in the transverse section, and the anterior and the lateral aspect. That is, the anterior side is actually lateral to the posterior side. So when we enter posteriorly, which is the approach to this joint in case of injections, the target is the posterior medial joint line. So coming to the technique, firstly, after consent and expectations of the procedure has been explained, the patient is put in the prone position. C-arm is taken contralaterally to give us AP, oblique, as well as lateral views. We have to remember that the capacity of the joint is about 2 ml. Just a word in here, am I audible or?
Audible.
Yes, you are perfectly audible.
Yeah, so
Yes, audible.
Thank you. So the capacity of the joint is about 2 ml. So in order to confirm the positioning of the needle, a maximal amount of about 0.5 ml of the contrast is generally injected so as to keep space for the eventual steroid in case we are aiming for a therapeutic injection. So this is, these are the diagrams. So the patient has been put in the prone position. A pillow is kept under the ASIS. Generally, the person who will be injecting, in this case me, is standing on the opposite side of the concerned joint. The C-arm is kept on the ipsilateral side, and the screen is kept at the ipsilateral side foot end. So that arrow actually marks the screen side. After skin preparations, the markings on the skin are done preoperatively. The PSIS are felt, are mostly palpated and marked. However, a PIIS, a lesser important landmark, are generally not, basically, they cannot be palpable most of the time and are marked on the skin under C-arm guidance. Now, if you look at that star that is there on the lower diagram, which just came on, that is generally the entry point as when you take the PSIS and PIIS, the location of the entry point is generally that star mark, and that is what the target is. Coming to the C-arm positioning, generally you can see the head end and the foot end in the patient. Generally, the C-arm is put in an oblique AP about 10 to 15 degrees. So 10 to 15 degrees oblique in order to elongate the joint line. And as you can see the X-ray picture, so that's the anterior. Okay, that's a mistake. So the anterior is actually the posterior joint line and the posterior is actually the anterior joint line. The posterior joint line is medially placed. So this again is a better view. So you can see a needle in the anterior joint line, right there, I'm sorry. An oblique view showing and confirming the placement of the needle in the anterior joint line. And this is the lateral view. I'll come to this in the video again. In the lateral view, which is basically the safety view, the only thing that we have to keep in mind in this case, the only structures that we are liable to injure in this particular procedure lies anteriorly, that is the so-called viscera. So this lateral view is the one which is a safety view, and we need to take it in order to make sure that the needle has not progressed inadvertently. The needle, as you can see in the lateral view again, is upward directed, and obviously we don't go ventrally. And this is an optimal image. About 0.2 to 0.5 ml of the contrast has been injected, and you can see how it delineates the joint. Both the anterior as well as the posterior joint line has been demarcated. If there is any resistance in case of while we are advancing the needle, generally we rotate the needle first, and if still there is any resistance, we generally advance or withdraw the needle slightly before injecting whatever is there in the needle. These are a few examples of suboptimal image. The first one, you can see the contrast has leaked anteriorly and is pooling outside the joint. The second one, you can see the contrast in the soft tissue and is evident from the nature in which the contrast has actually flowed. So these are some of the videos we have taken. This is I'll pause it there. This is like the patient is in prone position as I showed in the positioning picture. So under fluoroscopy, I'm trying to put in the needle. Needle has been put into the target in trajectory view, keeping the C-arm in EP. Okay, that is confirming that the needle is inside. I'll just now show the C-arm pictures again. I mean, after this. Okay, this is how the joint, the needle has been going in. It is, okay, that's the AP view. And once it is inside, we basically turn the needle on both sides, about 10 to 15 degrees oblique on either side to confirm it is inside the joint. Then we take a lateral view to make sure that the needle has not gone ventrally. And this is eventually, once we are happy with the position of the tip of the needle, we attach the extension tube and try to make sure again with the help of contrast. Here I generally clamp the needle so that to prevent any further advancement of the needle. Okay. So the contrast has been put in under fluoroscopic guidance. Disconnecting the contrast syringe. And then we go laterally just to make sure that the contrast is in the desired position and has not leaked ventrally. This is what we see once this is the needle is inside, and you can see once we inject the contrast how beautifully it delineates the joint line. Okay, and now once we are happy with the contrast, we generally inject the steroid. that is about how the technique is. Coming to a few complications, minority of patients very, very rarely can present with an immediate transient vasovagal reaction. However, the most common is an hello?
Yes, continue.
Most common being an increased pain and soreness of the SI joint for a short duration. We have to remember that there is a failure rate of about 10%. Very rare complications, however, more serious ones, a trauma to the nerves. Sometimes the patient can complain of bilateral lower leg weakness because of an inadvertent intervertebral foraminal injection, a hematoma, sciatic palsy, meningitis, infections, or even pyogenic sacroiliitis have been described, but as I said, very, very rare and serious. So thank you very much.
Thank you, Dr. Ray. That was really informative and at the same time well presented. But may I suggest something, that in your procedures with so much of fluoroscopy, you also wear a thyroid guard?
Yes.
Just by the way. So, thank you very much.
Yes.
And we quickly move on to the next, that is the radio frequency ablation of facets, technique, indications, complications, and video. Dr. Shaha, are you there? Manush? Dr. Manush Shaha, are you ready?
Yeah, I'm ready.
Manush? Yeah,
yes.
There. Right. So let's hear you, Dr. Manush Shaha.
Can you hear me now?
I can hear you, but your screen isn't shared yet.
Yeah. It is not showing share.
No.
Okay, just a minute. Can you see my? I can't see.
No, you're not there. We can only hear you.
Just a minute.
Yes, I think we are coming to your screen. Yes.
Okay.
Make it a full screen.
Yeah, please. Thank you.
Yeah, thank you.
Yeah, I would like to thank Dr. Abrar and the Spine Society of West Bengal for giving me this opportunity to be here. We'll be presenting a little bit about the radio frequency ablation of facet joints, which is relatively rare procedure. And so already my work is lessened by the previous presenters, and they have already told you about the anatomy, how to approach a facet joint and all those. This is just extension for more durable effect. As you see, the facet joint injections, when you do for local injections, many times they recur. Many times they recur. So this is the recapitulate of the anatomy. Our main target is the medial branch of the dorsal rami, and there is the components from the above and one level up. So this is actually the table showing what we have to do. If for the radio frequency ablation is a little bit technically more difficult than a normal diagnostic or normal diagnostic injections or normal block. So we'll discuss in little bit detail about the procedure, although I don't have entire video with me. So if it is a L1-2 level, we have to do the T12, L1, L2, at least one level up. And our target, please, sorry, and our target is the medial branch of the posterior primary ramus. And we have to be very particular about it when we do the radiofrequency ablation, because it's a nearly permanent damage to the nerve. So this is what is already explained, the Scotty dog appearance. This is a diagrammatic representation, and this is the medial punch. This is our target. This is the already explained by my previous speakers that this is the superior articular process. This is the transverse process in oblique projection. This is the eye of the Scotty dog, and this is the tunnel. This is the most consistent relationship, and we have to target here. So this is the typical appearance in an oblique projection. So you see the Scotty dog appearance. This is the pedicle, which is appearing as eye of the Scotty dog, and this is the area where between the ear and nose. This is the tunnel, which is covered by a mammulo-accessory ligament and forming the tunnel here. So this is a strict AP view, which is outlining this pedicle and the target area. So now you can see the needle here. This is a bit different from the other procedures where we are targeting the area upper and outer to the pedicle. So these are the normal needles for the radiofrequency ablations. So these are either 22 or 20 GLP, like 22 or 20 GLP needles, and this is the generator. Indications, as already discussed, this is the chronic low back pain, which we can attribute to the facet joint origin, and most common due to degenerative orthopathy. So pain can radiate down up to thigh, in some cases up to ankle as well. So here I want to make a precautionary note that RFA is used for ablation of different areas of the body, including the vertebral body, tumor, soft tissue. All this, please don't confuse them because they are not the same. We do RFA for the varicose veins. That is completely different procedure than the vertebral body tumor, soft tissue tumor, ablation of the osteoid osteoma. These are the completely different procedure than the ablation of the for the cardiac arrhythmias. So, however, the neural ablations are almost all the same, and the trigeminal neuralgia are treated in the same fashion what we are doing for the facet joint denervation. So pre-procedure evaluation, as already explained, is the clinical examination, X-ray, CT, we all do. CT is at times more valuable for the facet joint evaluation, as you can see the subchondral sclerosis and the perifacet inflammatory changes and osteophytes well. But for MRI is now standard, we can see the edema and all those. So prior to the RFA, we have to be very clear that the pain originating is due to the facet joint. If it is not due to facet joint, we are going to produce some other nerve defects maybe, and we are inviting complications. So I recommended is ideally one or ideally two or at least one diagnostic facet block prior to RFA to document the effect. The facet may be intra-articular, but peri-articular facet, for facetal nerve block is also works well. The if we are going for the RFA, you can actually during the diagnostic block target the medial nerve, medial branch, and that works. That is more useful. So diagnostic block may be CT or fluoro guided. Most of the people here more comfortable with fluoro, but as a I am an interventional radiologist, so this is all same for me, and I am very frequent with the CT as well. So one thing is that even recommended that even if it's 70 to 80% transient pain relief is there, then we can go ahead with the RFA for the facet joint. Ideally, 2 blocks at least 48 hours apart. Relief, if you want to document properly, then it should be around 4 VAS gradations. At least 48 hours gap between the diagnostic block and RFA till the anesthetic effect goes away. Investigation, like other presenters for other procedures explained. Mainly is the coagulation profile, viral serology depending upon the local practice. We have to stop anticoagulants, antiplatelets, and complications like any other procedure, mostly hematoma, localized nerve deficits, and possibility of recurrence. In technique, it's the prone position with all safety precautions. We take all the three views, AP, lateral, as well as the oblique view. AP to initially see the procedure and mainly alignment of the vertebral bodies. Lateral, not to overshoot because the needle should not go beyond the imaginary posterior line of the intervertebral foramen. Then we can additionally cause neuritis or damaged motor nerve damage here. And oblique is anywhere our projection to this to determine the scotida. RFA probe is 20 to 22 G needle, as I explained, with mild gentle curve at the tip. It is internally cooled with active tip of around 10 mm. We only do skin and subcutaneous infiltration. We should not go deep into the muscle or up to the bone, as we might miss the sensory nerve stimulation. Under fluoro, we advance up to the canal, and once we hit the bone, then mildly angulate it to get and sleep over the bone to get into the canal. So pre-ablation, we have to do a testing for sensory and motor roots, and that is mandatory. Sensory set at higher power in short pulses should reproduce the pain. It is 50 Hertz, 0.1 to 1 volt. We gradually increase, and if it should reproduce the pain by 0.5 volt. But if it is more than 1 volt, then we have to readjust our needle. And for the then once it is sensory is done, then we go for the motor nerve testing, and it is lower power, 2 Hertz, and we should not get response before 2 volt. We can see multifidus twitching at times, and if motor response comes before that, we have to adjust the needle as well. So once this is done, then we are ready for the ablation. Ablation protocol is always 70 degree for 1 minute at 50 watt, and then a second ablation about 75 degree for 1 minute at 50 watt. To reduce the post-procedure discomfort, we can inject a small amount of local anesthetic through the needle. And then mild compression, 45 to 60 minutes bed rest is recommended. It can be a daycare and OPD-based procedure. What we do is a stellate, the needle have a stellate. So with that, we go up to the canal, then took out the stellate and advance the RFA probe. Then complete the entire procedure, take the RFA needle out, and inject the local anesthetic if required. So this is our patient. What we she actually came with the left-sided severe low back pain reading towards the thigh up to ankle at times, and she is not able to walk properly. It is only on the left side, but we have done bilateral facet block in this patient. What we did is the perifacet block on the left as well as in the neural transforaminal injection at that time. So this transforaminal injection for that patient actually produced a severe motor defect immediately. We are actually a little bit scared that time, but it recovered well, and she got a good relief for around 3 months. But again, the recurrence of the pain was there, so she came back to us, and this time we decided to the left-sided RFA. So this is how we initially plan. This is a scotidog appearance, you see. And initially we are planning, and this is, we should not progress beyond this point. So we did a L3-4 level. And you see then our needle is here. In AP, it is like this, an upper and outer quadrant. This is followed by L4-5. And to complete, we also did L5-S1 level as well. followed by, in this patient, we actually did a nerve root injection at L4-5 level as well, L5S1 level as well. So following that, she got a significant relief for a long duration and then lost to follow. With this, I come to end of this presentation. We will be happy to take some questions. Thank you.
Thank you, Dr. Manush. That was a very nice presentation. And with that, I think we can, hello.
Yeah, please.
Could you stop sharing your screen, please?
Yes, please. Yes, just a minute. Yeah.
And
stopped it?
Hello?
Yeah, does it stop, I think?
No.
Not yet?
You're still on our screens.
Okay.
Yes, that's better. Thank you.
Thanks.
Thank you very much. Perhaps we should take the questions now, Dr. Abrar, or...
yeah, we should take some questions.
Yeah.
I have a question. Can I ask a question?
Who's speaking, please? Anindo.
Yeah, this is Anindo. So since we have since we have both pain specialist and an intervention neurologist here, intervention radiologist here, for can we ask a question? Can I ask a question to both of them? The question is, like, for cervical radiculopathy, I've during my fellowship I saw one of the neuro interventionists. He used to do CT guided nerve root blocks. So is like CT guided, like we don't do cervical nerve root blocks. We are more comfortable doing lumbar ones. So does addition of a CT guidance make the procedure more safe? And is it?
Can I answer?
And what is your experience? Do you recommend? Yeah, please.
Yeah, that's what I say. Because we use CT and ultrasound guidance for many things. So we are very comfortable with the use of CT guidance. Only, and in the cervical anyway, it is very, it makes your procedure more safer. You can go up to the neural foramina, or even the epidural injections are actually safer. And to tell you frankly that I do a lot of ablative other procedures like lung, liver, and recently what happened for all our ablative procedures, the needle size is only 16 or 17 gauge, but that produces massive pain when you do a visceral tumor ablation, and that produces massive pain. So for that we used to take GA. So now recently my anesthetic friend started this paravertebral giving blocks, and surprisingly in last 2-3 cases we never needed a GA. Patient was absolutely still. We had no pain or no yeah. So I think this is a great areas which we should explore more.
But you're using cervical nerve root block CT guide. You're doing that, sir.
I'm not much into the pain procedures. We do only a few, and most of the time guided by Dr. Abrar and requested by few other people. Then only.
But can I speak a little bit? I'm
Yeah,
Dr.
sure.
Goswami. I'm Dr. Goswami.
Yes,
The
sir.
cervical nerve root better to be avoided. So any needle placement through the transforaminal region inside the so it is better to be avoided, because the segmental arteries are coming from behind, and also the veins are both anterolaterally, and so there is every possibility, and there are many cases of hematoma formation, and so the complications have occurred. So it is better to be avoided. Even in CT, you cannot assess the vessels. And in the USG also, inside the foramen, it is very difficult to see. You can see only superficial structures. So it is better to be avoided.
Actually,
so
sir, I have little bit.
In
what
cervical.
you are saying is right. Yes, what you are saying right. But what happens? We do a lot of procedures. We do a lot of procedures, and we have to be a little bit careful. See, you in CT guided, you can go even by millimeter by millimeter.
Yes.
That is not you can go inject and come out. You have to be a bit careful. You know the vertebral artery, vertebral veins are there. Whereas the exact anatomical structures you can see of yourself, you can inject some contrast if you need it. So is there? Is if needed, yes. it should be avoided. But if you have no option, but you can go in, no issue.
If you miss Subhrata sir's lectures, my question is, Subhrata sir, who is your candidate for cervical epidural injection, sir?
Yes. Hello.
Yeah, Subhrata sir, I have a question for you. Who is your ideal candidate for a cervical epidural injection?
For a cervical epidural injection, if there is a radicular pain and the patient has no motor weakness or sensory loss, but there is a disc prolapse and the patient also, then we can go for this and severe pain. That is the ideal candidate for a cervical epidural injection, and it is more for acute pain and not for chronic pain.
Good evening, Dr. Shoykot Sarkar here. Am I audible?
Yeah.
Hello.
Yeah, please.
I have 3 questions, 2 for Dr. Somojit Basu sir. Number 1, that for L45, I am giving a case that L45 paracentral or posterolateral PIVD, if you target selective epidural nerve root block or transforaminal epidural block, so what will be your level of injection for L45 paracentral disc prolapse, posterolateral disc prolapse? Question to Dr. Somojit Basu sir.
Yes, Somojit, please come in.
So the important clinical and radiological correlation is that you need to find out the exact route which is getting involved clinically from the history and your clinical examination, and then have a very careful survey of your X-rays and MRIs to point out which route you are targeting at. If it is a paracentral L45 classical disc prolapse, you should get only L5 root affection, and you should target L5 only. Now, as Shomayu pointed out, if you put your injection in the Campion's triangle, you're likely to inject into both L4 and L5. But if you just do it underneath the pedicle of L5, you're going to target the L5 root alone. In my personal practice, I usually do only L5 root block if I'm convinced that L5 root is the culprit. Whereas if it is a forlateral disc or even a subfacetal disc and I get features of L4 radiculopathy, I'd be more keen to inject at L4 only.
So I think the message from you is very clear that for a patient with L4-5 paracentral posterolateral disc prolapse with L5 radiculopathy, the target for selective epidural nerve root injection should be L5S1 transforaminal.
Only L5.
L5, yes. Second question is to you only, that which steroid do you prefer? That is depomedrol, that is methylprednisolone acetate, or it is the triamcinolone?
So for the first half of my 16 years, I had been using depomedrol, but subsequently there was a litigation which came about a decade back. One of our colleagues in Delhi had a hard time, and from then on I have shifted on to triamcinolone.
Triamcinolone 80 mg.
Yes, 80 milligrams and 2 milliliters of bupivacaine.
Oh, okay. Thank you, sir. And last question, though Abhishek mentioned about it, but question to all the experts, that one of the contraindications of giving this steroid injection is diabetes. It is commonly said, but what is the exact cutoff, or what do you mean by uncontrolled diabetes? But can you tell me that the patient with diabetes, this is the level or this is the HbA1c level, for that we cannot give injection? I have never found anything like that, that this is the cutoff. Only have some, this is a qualitative type of thing, that is uncontrolled diabetes. Any quantitative thing level for that the patient is diabetic, but we cannot give injection. It is called uncontrolled. What is this? Direct question to Dr. Abhishek Da, but I think any expert can enlighten.
I think in any presentation given by a presenter, whenever he lists it under relative contraindication, what he wants to actually convey is, I don't believe in them.
Pardon?
So I mean, like, I don't think there should be any blood glucose level which should be a threshold beyond which injection cannot be given. But generally, theoretically speaking, if you're asking, what I found was like an injection, I mean, very commonly used in case of joints also, as you will know. A patient with poorly glycemic index is Like, you tell the patient to beware, because next day when he does a fasting blood sugar, he's going to find it very high. So I don't think it's a contraindication, but more as a caution to the patient that next day when you do a fasting blood sugar, it may come to be quite high. In fact, one patient I remember about 6-7 years back, known diabetic with good control, I had given an injection and the patient came with onset of hiccup for 1.5 days, and it correlated with his glucose level. Exactly, like 1.5 days, the glucose started coming down after that, and the hiccup went off.
So for that particular patient, did you take the fasting blood sugar on the day of injection and compared with the post-injection fasting blood sugar? I don't think so. Is it?
So, listen, these patients, like some of these patients are on insulin, and many of them actually do a early morning CBG. Okay. So when this patient came every day, it is under control, but that particular patient, and it has happened in many other patients also, when the next day fasting CBG they are going to do, it comes out to be quite high. And 2 or 3 times the patients have come back and told, sir, today's blood sugar is very high. I don't think there is anything to be of concern, but the patient can get a bit apprehensive about what happened. The sugar level is shooting up.
No, that you have to explain.
May I ask?
They will continue to have this high blood sugar for 2 to 3 weeks. You must tell them beforehand that you are going to get high blood sugar in the post-operative period.
I have a question for Dr. Shomujit Basu.
I was just 1 minute. I was just going to ask Dr. Devanjali Ray if she would come in on this blood sugar issue.
Hello, am I audible?
Yeah.
Yes, you are.
Hello, yes.
Yes, you are. You're audible.
I would agree with Dr. Abhishek Roy. Nothing is contraindication here because patient has come for us to get relief from some pain. So see, if it is very high, I would like to optimize with some short-acting insulin. Then I will take the follow-up. It's my opinion completely.
Okay, thank you very much. Let's go to the next one. I think it was.
Yeah. Somebody said if you are doing a nerve root block if you're doing a foraminal injection as a diagnostic procedure and as a pain procedure, I mean to give pain relief, would your needle positions change, or how do you does your technique change for
Too much of noise. You have to repeat your questions.
May I ask everyone to mute themselves? 1 minute, please. May I request all of you to kindly mute yourselves, mute the mics, except for the ones who are speaking. Yeah, thank you. Please go on.
Yeah, thanks, sir.
Dr.
If you're doing a foraminal injection as a therapeutic procedure and a diagnostic procedure, do your needle positions change?
No. I'm a great believer of the fact that multiple routes do not come to you at a single time. It's if you have a disc prolapse at 3 levels and the patient goes with sciatica, it is your challenge to pick up which is the disturbing route. And not, I mean, I find so many of people who inject in 3-4 nerve roots and a little bit of facet blocks and a little bit of multiple root blocks and a little bit of SIJ injections. I get absolutely frustrated when I see this, because then where is the clinical science behind the show? Where do we endeavors to localize the pain? I think we should give some more time and effort to localize the pain.
And sir, are you doing epidural steroid injections and facet joints very often? I mean, like these 2 procedures, like the popularity of these 2 procedures are coming down with time. So like a question to all the senior experts, like midline epidural steroid injections and facet joint injections. Has your practice of doing these 2 procedures come down with time, or has there been?
I have never injected epidural steroids.
Midline
I have very rarely found the actual utility other than a patient who is inoperable due to whatever reasons, due to whatever medical reasons he has, multiple stenosis at multiple levels, and all of them are central stenosis, but he does not, but he presents with just neurogenic claudication. Possibly that would be a very wild guess. I don't think I have advised for epidural steroids over the last 10-15 years. I've never given myself one. If at all I find the necessity of doing that, I'll send it across to my anesthesia colleague and pain physicians. I would possibly send about 1 or 2 a year, very ready. And lumbar facet block, as I have shown you, I have maintained that picture which I have shown you in my presentation for about 12 years now. In the last two, that was the only couple of patients which I have given where I could identify that lumbar facet is the pain generator. Otherwise, it's pointless to go on injecting at multiple lumbar facet blocks.
It's quite interesting to note, sir, that I was going through the NICE guidelines also. And what they mention is they've asked people to stop doing procedures purely for back pain, spinal injections. That is number one. Number two, they've said that midline epidural injections for spinal canal stenosis should not be done. So this is what the latest NICE guidelines ask the spinal surgeons to do. So that is something, contradicting up.
Thanks, Anindya, for pointing that out. Can I ask one question to all of you who are doing pain procedures? How many of us would check for, say, the coagulation profile or the blood sugar levels, or for that matter, checking out any other parameters before this procedure? I would take the opinion of the pain specialist first and then my spine specialist colleagues.
We all check blood pressures.
Yes. Coagulation profile also we check.
I've got the response from Debanjali and Shubhrata.
Blood sugar level before. Can you listen to me? Or even
yes,
that, yes. This, what we have. Debanjali, you continue.
Sir, what I wanted to say that in case of elective cases, we always check the coagulation profile, fasting blood sugar, and urea creatinine. This minimum basic investigations we always perform.
And is it a common practice with all pain physicians out here, including Dr. Manoj Shah, intervention neurologist, intervention radiologist?
I can say that in all our procedures, because I do a lot of other procedures as well.
No, I'm speaking of blocks only. Yeah. I'm only speaking of pain relieving blocks.
Even then, all the procedures, even for FNSC, we do a coagulation profile, sometimes just to avoid any possible litigation.
And Shubhrata?
Yes.
And what about my spine colleagues? Abhishek, Anindo, Shumayu.
Even if you don't have a creatinine, blood sugar, and coagulopathy.
Hello.
Can we raise up our hands? Any of us who does any sort of these blood tests before an injection? Any one of us can raise our hands?
I do.
Yeah.
So, Dr. Abrar, what do you do? And what is your protocol, Dr. Abrar?
The protocol, basically, I will do the HIV serology, hepatitis serology, along with the coagulation profile in all the patients. And I will optimize blood sugar level before.
I've been thinking of doing a test, but I haven't done so far.
No, we do.
So you do coagulation profile also?
Yes.
And what about Shomayu, Shoikat?
I only do the blood sugar test. That's it. Never checked pressures, and I've never thought of it as necessary. Coagulation profile, I think I'll do from now on because everyone's saying so. But I don't think anything else.
As mostly they are elective procedures, so I do all the blood tests. There's no point holding back coagulation profile or blood urea creatinine. I do it, and it's a planned procedure. I do it beforehand.
And Abhishek, Shoikat, Chinmay?
For me, I always check the blood sugar and the hemoglobin total count, definitely to rule out any hidden infection. But coagulation profile, so far not yet. But after this discussion, probably from the next time, I will do the same.
I do the blood investigation.
Coagulation profile, but I don't do the HIV and viral serology, other viral serology. But I do all these for last
Chinmay, the one thing just I want to highlight that viral serology has nothing to do with the procedure. It is actually the hospital protocol, whether they are allowing your patient to enter the OT for the without the serology markers are done or not. That is the thing. And we are very hardly concerned about the serology for a just transforaminal nerve root block as a surgeon, I think. But it is the hospital protocol that they don't allow any patient inside the ward.
No, you can actually take in our hospital, you can take the patient inside, but everything is disposable. That adds to cost. Everything you have to use disposable.
Thank you. I think we are getting late.
So what would be the bare necessity test required then for an injection procedure?
No, Shumaji, 1 minute. I think since Shumayu asked the question, I think there is a consensus that none of these are probably required because we don't believe on the coagulopathy. Even a total knee nowadays, I think even with I'm telling you, even joint replacements nowadays we are doing with the deranged, coagulation profile sometimes. 1.65 we are still doing it. Ecosprin we are not stopping. Clopidogrel we hardly stopped it for 2 weeks. I think more of a medico-legal aspect. I think this is
medico-legal because the trauma procedures are done with the aspirin on, and coagulation maybe INR maybe more than around 1.5. So for injection procedures, it's very hard, very rarely cause and medical legal problem. That is why we are scared and we do.
I think
so from the medical legal point of view, what is the consensus of what we have to do to proceed with a procedure like this?
I think I'll come in here with a simple question that, look, if you have done the coagulation profile and if it is altered, you have a problem. And then after the surgery, I mean, after the injection, there is a problem and it goes to court. Well, if you say that no matter what, we'll do it, in that case, you are really in trouble because in court you will be asked, you knew that his coagulatory profile was wrong. Why on earth did you do it? And because you see, hardly any of these procedures can be called life-saving emergency procedures. No. None of them can be. So they are not life-saving emergency procedures. So if you do it and you establish that there is a problem with the coagulation profile, I would think it would be safer not to proceed right away, but correct that.
So basically, if you have got a coagulation problem, then the spinal anesthesia is not indicated. Understand? You can have a hematoma, you can have a paralysis. Similarly, you can have a hematoma around the nerves also, and you can be in medical legal trouble. It's better to get it done.
That's right. That's right. That's what I was suggesting. That if you have, just because it is protocol. I mean, it has to be done. If you haven't done it and there's a clot, you're in trouble. If you have done it and there's a clot, there's trouble. Unless, of course, you have done it and you've corrected. You've taken steps to correct that. For example, withdrawing. But then nowadays, most physicians will not allow you to withdraw clopidogrel or aspirin in cardiac compromised patients. Most physicians will say, please don't do that. Don't compromise the heart. So we do have a controversy there. Perhaps Dr. Shomujit will take a call on this.
I think from the societal point of view, Dr. Kunal Sengupta and Dr. Abrar can point a couple of young guys to look into the literature. We can involve one of the persons from Pain Society also to look into the pros and cons and bring out a sort of a white sheet. This actually can be taken up to the All India level also. So once we have something which is of evidence and which comes out as a white paper, with both societies in conjunction, I think that would be a very good starting point to tell the rest of the country that this is what we found out. I would ask Dr. Abrar to point a couple of guys from our side and possibly from somebody from their side also to form a joint sort of committee so that it looks into it, because this is something which is very pertinent. All of us are doing quite a lot of these procedures and none of us wants to languish in jail. So it's a nice practice actually to have some fallback upon guidelines.
Can I say something? Can I say
So
something?
that, yeah, I think we'll take the last comment from Dr. Manusha and then we'll have to wrap up.
I think we'll have to pack up.
OrthoTV, I'm
It
sure
is
is
very
getting
it is very difficult to establish anything. You know, what you say that aspirin, the simple aspirin of 0.75 of 75 milligram as a just a every day we are taking as a preventive small dose. With that, there is established everywhere that nothing can happen. You can go ahead. Okay. And we have seen several life-threatening GI hemorrhages. And that goes on for 10 to 12 days till the half-life is over. Okay. So it is very difficult to establish. For all vascular procedure, we don't stop aspirin. For non-vascular procedure, if possible, we have to stop. If not, then we have to go ahead.
Meeting, ma'am.
Thanks for your input, Dr. Manusha. I think for the paucity of time, it was an excellent discussion for all of us. We got educated a lot. And can I ask Dr. Abrar Ahmed to wrap up and give the final comments?
I think it was a great, very informative session. I think all of us have learned certain new things from other people. I must thank other, Dr. Manasa, who is from the radiology department, and the two of our pain specialists who are the invited guests in this. I especially took this because this thing is not routine thing which we take. But every one of us is doing all these pain procedures. So I thought that we would have a session on this thing. And I hope that all of us have learned many new things. Thank you very much for spending your valuable time. And hopefully we'll meet again after 3 months on a new topic. Thank you very much.
Thank you.
Thank you, everyone.
Thank you.
Safe Sunday.
Thank you, everyone.
Sir, good evening to all of you, sir. This is Chandraketu from INTAS, and I sincerely communicate my thanks to the Spine Society of West Bengal for allowing us this opportunity for this webinar on pain management, primarily spinal pain management. I hope that we